It is such an honor to see you all here. We have a full house here. Almost 175 individuals are joining us, and we've got, I think, about 400 to 500 online. So welcome to this national community, all focused on trying to improve American healthcare. So just a couple of housekeeping details before we get started with our main event this morning. All of you should have a name tag. Hopefully seen that. If you haven't, you can get one at our registration desk. And there's like there's a dot on there. So that colored dot tells you a little bit about the different roles that are here. So I'll just start with the blue dots are individuals here who are part of the Heroes team. So actually, will you just take a minute? If you're part of the Heroes team, will you just stand up for a minute? So first of all, these are like unbelievable people. They've been working tirelessly for the better part of this past year to make this program a reality. So thank you to them. And they're all here. We're all sort of here to kind of circulate and work with you all as well. What I'll then say also is for today, we really encourage participation and questions. So if you have a question, we're going to have a number of times when we'll be able to answer them. Please email your question with your mobile device to heroes, HEROES, at ARPA-H.gov. And in the subject matter, please write the word question. And that way it'll go to our team here, and then we'll either answer it live, and if we can't do it live, we'll bring it up. We'll put it on an FAQ as well. With that, what I'll do is invite you all to sort of sit back and really, I'm like incredibly proud of the fact that we're going to be joined this morning by two just incredible federal leaders that are going to set a little bit of the stage for not just the Heroes program, but more broadly about how we're trying to make healthcare together, the sort of shared project we're all part of. So I'm going to hand off to Dr. Renee Wegerson, who is a PhD biologist who is the inaugural director of ARPA-H. And she's going to tell you a little bit about that role. But one of the amazing things about Renee, who's standing here right in front of me, is the fact that what she has brought to the agency is not only the focus on the innovation and sort of the deep science, kind of taking these foundational moonshots, but importantly also a sensibility and recognition that those investments and those incredible discoveries gather meaning only by being pulled all the way through until it actually helps the Americans and not only that are here, but really citizens of the world that and this broader community we're part of. And it's in that sort of vein that we can see the Heroes program is part of a much broader set of how we're thinking about improving American healthcare, from both the bench side to the bench all the way to even society as a whole. So it's been my great privilege to be part of that, see how that has been occurring. And with that, I'll hand over the floor to Dr. Wegerson. Thank you.
Thanks, Darshak. Oops. Okay. Good morning. Really welcome everybody here to the Heroes Proposers Day. Having been a former program manager, this is really like one of the best days of a program manager's life. Making people show up to hear about your big idea. People come online. The second big day is when the proposals come in. You get to see how people are actually rethinking the way that they approach science or the challenge that the program manager has set forward. So for those of you that don't know me, I have this incredible privilege of being the first director of ARPA-H. I had been at DARPA before. I had done startups. Having a startup in the federal government is not for the faint of heart, but it's been really the team, the Heroes team that you heard about today, champions like Arthi Prabhakar that you'll meet here in just a moment, that really make this possible. But you also really make this possible. So I want to talk a little bit about what is ARPA-H. We're an agency, the Advanced Research Projects Agency for Health, that President Biden launched in March of 2022 that is modeled after DARPA, this incredible business model that the Department of Defense used to bring us things like stealth technology and the internet. Our mission at ARPA-H is to accelerate better health outcomes for everyone. We'll do this through our R&D investment, but importantly, we also want to create new paths to financial sustainability. Because unlike DARPA, that has the Department of Defense to pick up and be an advanced developer of a lot of the innovation, that doesn't exist for ARPA-H. That's not HHS, Health and Human Services, is not synonymous with DoD in that regard. It's the private sector, it's the investor community, it's some of the larger government agencies. And so having this community here and having the creativity brought to us by folks like Darshak is absolutely critical. One of the things that I hope that you walk away with today is just thinking, wow, that is not like any government agency that I've ever encountered, because we really do prioritize not only the innovation, but also in the design of our programs, we're looking at the accessibility, the customer experience, the user experience, and the sustainability. That's built in by design. And we've launched about 10 programs at this point. And Heroes in particular is rethinking how we incentivize really looking at costs and accessibility to improve health outcomes that Darshak will walk you through. You're going to see a lot of Darshak these next 2 days because he fulfills a very unique role at ARPA-H for the program manager. So the other very important point that you should know about ARPA-H is that I don't set a technical agenda top down and say, thou shalt fund these next programs. We actually look to the community for change agents, these incredible doers that have a brilliant idea of a challenge they want to take on, in our case, in health. And they come to ARPA-H and they pitch that as part of their candidacy. So Darshak about a year ago came and pitched this idea for Heroes. And what that comes with when you bring him on board is actually a term limit. So he has a 3-year term limit, meaning every 2 weeks that goes by, 1% of his time is up. So that's going to bring, I didn't put that urgency on him. He will bring that urgency to you. But that's how serious we are about this mission and making this change. He can renew for an additional 3 years, of course, too. So you won't lose him in 3 years. But by doing it in this model, we actually want to catalyze this entire ecosystem through our program managers, these incredible change agents. Through our program design with Heroes in particular, we want to improve access to preventative care. We want to not only influence the marketplace, but we want to establish a sustainable market that will support health outcomes. By creating this data set, we can actually influence, hopefully, the whole ecosystem and potentially others in government to be able to create a home for programs like this longer term. The other thing you should know about an ARPA is that we're not a forever funder. Our funding is as disease agnostic. It's not focused on a specific technology, but instead an investment where we see our investment can create an asymmetrical advantage to advance the state of the art, but then those projects have to leave ARPA-H on the back end. And so during his every 2 weeks that goes by, he'll also be thinking about what happens on the last day of this program. He doesn't want it to fall off a cliff, but instead he wants it to be sustainable. The way that we do this at ARPA-H is through some very unique authorities that afford us ways that we don't issue grants, actually, but we issue contracts, cooperative agreements, other transactions that may sound like jargon to you right now, but you will be hearing from our contracting teams over the course of the next 2 days to explain how that's more of a business-to-business like interaction. We want to make it simple to work with government and a pleasure to work with government going forward. And then last but not least, when you can tell that a program is really making an impact in the community is by changing the conversation. And I see those of you that showed up today, I did look at the registration list, the fireside chats. Fundamentally, we're changing the conversation around incentives and around health outcomes. And we can't do this without our champions, our program managers. We have champions in Congress as well. So I'm very pleased to say that ARPA-H has unanimous support. Every member of Congress that I've met has also been touched by health, whether their own personal health, a child, or somebody that is very near and dear to them, and they want those better solutions and those health outcomes.
I think what we're going to sort of transition to now is a little bit of a deep dive into what the program actually is. So I think many of you may have seen the materials. We've made a lot of it available. But as with many things, sometimes just talking something through helps us understand the program in a way which can be incredibly helpful. So I'm going to take the next 40 minutes and walk through what the Heroes program is. And that'll set us up for these next sort of days we're going to be spending together. So with that, I'll just, I'll start off with like a little bit of an analogy. So in the world of ARPA and ARPA-H, we always start with like a what if statement. Like, I mean, we all need a dream, right? Like, why are we all here? We want to work on hard problems. We want to make an impact. So this is sort of, we always start with the what if statement. So here's ours. What if we move from a sick care system to a system that truly rewards better health? Can we do that together? And that's the challenge. But what does that actually mean? So I'm gonna let me take a step back. I'm a late in life sports fan. So take a look at this data. Hopefully you can all see this. This is depicting a basketball season. Can anybody just yell out what is actually happening inside? Can somebody interpret what is this? Anybody? Just yell it out. Could be recovery. I'm being more literal. Like what is actually this data referring to? Say anybody?
NBA season history for the last 10 years.
Which one?
That's an NBA team. I don't know.
Right. Basketball, NBA, definitely. Yes. This is, yes. Who said that? Say it loud. Cleveland Cavaliers. This is, that's right, baby. So this is what's being shown here is the departure and then the triumphant arrival of the great LeBron James. And what you can see here, and this is what I'm getting to, and you're like, what does this have to do with heroes? Like, I don't get it. Like, so what we're trying to show here is look at what happened when LeBron James left and then when he came back. The point I'm making here is that in basketball in general, and this is an analogy that might be familiar to some of you, the success of a team was almost always about the single superstar, right? For those of you that are football fans, you saw what does it mean to have an incredible quarterback? I'm from the Boston area. But then look at what look at what Kansas City's accomplished. Like in that sport also, having a single superstar is the difference maker. We think about healthcare a lot in that same way. It's that one discovery, like that one sort of breakthrough, that's going to fix everything. I'm going to use a different sports analogy here. Some of you may recall this, 2016, the Olympic Games, the U.S. women's soccer team was incredible, heavily favored to win the gold medal. And these are screenshots. I took that one from ESPN Sports Center. I'm just going to point this out and just take a second on this. Shots on goal, the U.S. 26, Sweden 3. You know, the American women had the ball 2/3 of the time, and yet they still lost. Why? And the reason, and the reason for this analogy is that the nature of soccer is that it is a very different game. Unlike the game of basketball or arguably football, soccer is all about the weakest link. In other words, you're only as strong as the player who has the biggest chance. Think about all the things that have to happen, right? The ball, you got to defend the goal. Like you got to get, your defense folks have to get to the midfielders. The midfielders have to get to the striker. So much has to go right there. I say this because this is a lot to say about how we should be thinking about healthcare, and in particular, what the HEROES program is trying to do, which is that we need to move beyond this impression of having the single sort of intervention, the single person, the single institution that's going to fix the problem, and actually learn to play as a team. I think about it. I'm a pediatrician. I'm a pediatric cardiologist. I still see patients. I was in clinic yesterday morning. I think about all the things that have to go right to bring a child into the world and bring them to a healthy future. You want to make sure they have a healthy prenatal course. They're born in a stable family. They need to get the right education, access to care, all the preventive stuff, and all the societal supports around it. Nobody walks this path alone. And if we're going to have significant impact in healthcare and in prevention, we need a system that also encourages and creates the right incentives for that type of way of thinking about healthcare. And that is what the HEROES program is going to try and address with the collaboration of the folks in this room. So what does that actually mean on a practical level? Well, what's the problem we're trying to solve in the HEROES program? So simply put, as you heard from Dr. Pabakar and also from Dr. Wegerson, we are not getting what we should in the United States. American life expectancy has been flat for decades, even declining in the post-COVID era. Why is that? I think this is not a mystery to all of us. Despite massive spending and an incredible technological level of talent in the US, we still suffer from and arguably some of the highest rates of preventable health conditions in the United States. Rates, as you can see, the type here is small, but ischemic heart disease, lung cancer, road injury, COPD. Why is that? And this is, again, what we're going to think about solving for in the HEROES program, which is that it's no surprise that in the American healthcare system, you get what you pay for. Well, let's sort of break apart that challenge of life expectancy. That's a lot, you got to, if that's at the end of the line, we need to know how we're going to get there. So just about a year ago, we convened federal leaders, senior leaders, CDC, NIH, CMS, FDA, HHS, the organizations that work in mental health. And we said, well, let's take that apart. And we looked at data, said, what are the drivers of those disparities? Can we actually identify them and take that apart? And we zeroed in on these four, which are some of the four outcomes. You're going to be hearing a lot more about these. Maternal health, cardiovascular disease, opioid overdoses, and alcohol-related health harms. So when you sort of look at those contributions, they play an enormous disproportionate impact in those challenges around life expectancy in a meaningful way. One of the other things I want to point out that's so interesting is that these challenges all have their own geographic distributions. They have their own age sort of biases, and also ones that depend on demographics, ethnicity, and income as well. So in many ways, the problem that we're focusing on here, it goes beyond just healthcare. It is structural. In many ways, we talk about there's structural barriers to achievement. People talk about structural racism and other. This is what the HEROES program is. It is structural anti-racism. It is structural improvements that actually fundamentally shift the incentives so that what you all are doing, it's not only the right thing to do, but if there's one thing we've learned, it has to also for your organization be the smart thing to do for their bottom line. So you get what you pay for in healthcare. So I'm not going to get into this slide other than using this as a way to set up the three factors that the HEROES program will address before I jump into some of the details around the program, which is simply put, we ignore early signs. Let's say, arguably, think about maternal health care, lack of prenatal and most importantly, postpartum care. Only about a quarter of women in parts of the country on Medicaid ever get any kind of care after they leave the hospital. We miss significant degrees of anemia. You've all heard about syphilis being an epidemic because of lack of time. You can just go down that list. And yet when a catastrophic event occurs, that's when the healthcare system springs into action. Heroic measures are taken, but that's sort of what we're set up to do. Why do we do that and not have a system where we actually do that care all along? We believe in the HEROES program, there are three fundamental drivers. The first is a lack of an actual buyer of the outcome that matters. Think about it. Who today is actually responsible for paying for and creating an incentive to, say, improve serious obstetrical complication rates at a geographic level? That person does not exist. The second is who is actually, not only is there not an incentive, who is responsible for that? So I'll give another analogy. I think this is one of my personal experience, but I think I mentioned I'm a pediatric cardiologist. I, for years, was involved as one of the leaders of the high-risk obstetrical service in central Massachusetts in a prior role. And to this day, if I were to go in and say, of the people who just delivered, can you give me a list of those that actually need a postpartum visit in the next 3 days? Nobody can do that. Why is that? Well, it's because the financial accountability is also diffuse. We have multiple payers. If you've worked in commercial health insurance, Medicare, Medicaid, the uninsured, no one is actually responsible. And when you only have a small piece of the pie, your imagination is severely constricted in terms of the kinds of things you can do at a community level. And finally, so I mentioned the first is the lack of a payment incentive. The second is a market fragmentation. The third is a lack of adequate just-in-time data. I would defy us to say, do we know, for example, the rate of overdoses in the county in which you live in? Do the leaders who actually are delivering the care even know what they're shooting for? We would say the answer is no. And that's the third leg of the stool, so to speak, that the HEROES program will address. Well, to begin with, we have to know the target we're shooting for. So the first piece of the puzzle for the HEROES program is saying we are going to collectively develop single-threaded ownership in a specific geographic area for these outcomes. In other words, we know, I think many of you work in complex organizations. When you kind of have 10 different things you're accountable for, you end up doing 0 of them. So the first piece is that we create and we are defining an outcome. We're going to be spending a lot more time talking about these and digging into them, but I just want to lay these out so that you hear them. The first outcome is and these are population level, serious obstetrical complications. All the 25 things that we know define what a serious adverse outcome during delivery is. We are extending that to 60 days postpartum. That is new. We are also going to add some behavioral health complications during that time. That is outcome number 1. We'll talk about that in a lot more detail. Outcome number 2, the 10-year risk of heart attack and stroke in a population. That is something we have not ever looked at a population level. You can actually calculate that with very high fidelity. And most importantly, I want to point this out, we have evidence that you can make radical changes in all of these outcomes in short periods of time. It is hard, but it is absolutely doable. The third is the rate of opioid overdoses measured by EMS visits in an area. We actually can get that in practically real time at the county level in the United States now. The third is alcohol-related health harms. Just put those out there. Think of it. Now, I just want you all to think about what does it take to actually make an impact in those areas at a geographic level. By that, we mean a contiguous population anywhere from 500,000 to 5 million people. We started off today with saying we do hard things here at ARPA-H. I think all of us recognize that is not an easy thing to do, but it is absolutely doable, particularly with the talent here. Our job is to create the right incentives, the programs, and the support. We look to you to be the leaders that actually deliver that in a meaningful way. Just as there's any kind of moonshot being taken, this is a moonshot for public health, the likes of which and the scale of which has not previously existed in the United States. All right. We're going to cut to sort of some of the details here. What is this supposed to look like? Okay. Sorry, can somebody yell, what is the color of the health accelerator button?
Green.
Green. If you have a green dot, I'm honestly, we'll give you a green dot if you really want one to, if you have a green dot, you have indicated you want to be a potential health accelerator. I want to talk about what that means and what we're asking you to do. So a health accelerator is an organization that thinks they can actually address one of these issues at geographic scale or be part of a solution. When we are looking for potential health accelerators, we are looking for an innovator that can make a difference. That could be a nonprofit. It could be a startup. It could be a provider system. It could be a payer. We are open. It doesn't matter. The only request we make is that it can't be a primary government agency. Meaning you could be a state med school, you could be a managed care plan, but you can't be like a state. We also believe that these problems are complex. And one of the reasons you're all here today together is we hope you meet each other. You start to create a community. I'm sure you all come from communities, but we believe collaboration will also be important. So a health accelerator is a organization, it could be a consortium that gets together, says, we are going to fix this problem in this geography. That organization is going to sit down and go online. And you're going to get a demonstration of this tool tomorrow. This is the Heroes Outcomes Toolkit. So step one of the journey would be to say, hey, here is the outcome we are interested in. By the way, this tool actually exists. It's live. So proud. One of the things I love about working at ARPA-H and the team we have here is from the conception of this tool to the actual utility. And think about it, that's contracting, federal contracting, design, product testing, sort of quality control, multiple data use agreements for national data sets and 4 outcomes, all that. This is a twinkle in our eye in October, November, and now it exists. That's the speed at which we work. And as Renee said, every 2 weeks, 1% of our time goes by. This is going to be a 3-year performance period. So just the same as my term is 3 years, you too can be part of a 3-year program to try to deliver these results. Anyway, so you will, as a health accelerator, you will choose one of those. When you click into that, you will then get access to a map. You click and say, this is the area I'm interested in. You build your cohort using that map, and then that will then serve as the core of your proposal. In other words, I'm in this area. I would like to select this geographic area, and then the tool will make sure you have the minimum population size, and also, importantly, the outcome that you select, the performance in the area that you choose has to be worse than the national average. So that's how we think about fairness and equity. We don't define it in sort of an arbitrary way. You literally just choose an area that needs help. That's how we're defining it. Once that is done, you then have a health accelerator, you've chosen an outcome, and you have a geography. That's the foundation of the HEROES program. That's where a potential abstract submission would start. Now I'm going to so there's a lot going on inside, and I hate like putting up complicated slides. So you can also not look at that and just look at me, but I'll leave it up to you. So here's what you've done. You've picked a target as a health accelerator. For example, you have gone out and said, I am interested in improving the rate of opioid overdose in this area. I have identified a region with about 600,000 people, and I've brought together a consortium that can do it. Maybe there's a couple of provider systems. Maybe there's a provider system. Maybe you've got a digital health service that can sort of find individuals. Maybe there's a community-based kind of on the ground, like sort of community health workers. You put it together in a way, and maybe even a technology or a potential treatment that could be helpful. You've put that whole thing together. Then what you do is you say, okay, we give you the national baseline. We're going to spend a lot of time on this, by the way. In other words, the target you're given is sort of the national baseline of that rate, lightly adjusted so that it looks a little bit like your population. Again, one of the things we've learned is we don't want to overcomplicate risk adjustment. So that'll be sort of what you shoot for. And then we look at the place you've selected. As time goes on, there's the national trends may change. There's a difference there. And then your population, hopefully wherever you're going to be intervening, things get better. If that gets better, we use what's called a difference in difference. And then that is the target you actually would be committing to. I'll talk about that in a second. In other words, simply put, you need to make that outcome better. I want to emphasize, we don't tell you how to do it. So I want to come back to where we started with the soccer example. We recognize that you are playing soccer. It is complicated. What you're going to be doing in your area may be very different than what you need to do in a different geography. You certainly don't want to file plans with us and all that stuff. Literally, you as a health accelerator own this problem. It is up to you to solve it. The only thing the HEROES program will be actually measuring and incentivizing is the outcome itself. It is an enormous degree of freedom. And I want to emphasize that it is nothing to do with the traditional healthcare billing platforms. In other words, this has nothing to do with shared savings, has nothing to do with sending any kind of claims in for payment. This is only incentivizing the population health improvement. We have in effect securitized a population health outcome by analogy. In any event, let me sort of come back to this. So you've chosen a geography, you've chosen the outcome upon which you're going to focus, and this is where the magic happens. If you are selected as a health accelerator, ARPA-H will commit to purchasing that outcome from you. In other words, as surely as you go out and create revenue by pre-selling something and you know you have to build it, that is exactly what we're going to be doing at ARPA-H. We will advance purchase, or we are proposing to advance purchase in each area, $15 million. So that's what you get if you succeed over time. We'll talk about how that's doled out. The very first payment, by the way, you get a guaranteed $2 million, just for sort of showing up and sort of satisfying the program requirements. After that period of time, the payments then are based on your performance every 6-month reconciliation. We will preference organizations. And as Renee said so importantly, these programs have to be sustainable. So we will be preferencing organizations that also find other people to purchase the outcome. In other words, ARPA-H is committing to $15 million. We are setting an aggressive target. It's a target, it's not a requirement, of a 2-to-1 match. So for example, if you are committing to improving, say, cardiovascular outcomes or predicted in a geography, ARPA-H is the first piece of your financing puzzle. We will preference organizations that then also say, well, hey, that we found a payer. They're also interested. There's an employer. There's philanthropy. There's a potential other source that's also interested in coming in with us to supplement that outcome buying tool. That is the key to sustainability. We will be looking for that. We're going to be spending a lot of time. You're going to hear from several of the nation's experts in how to think about setting up outcome purchasing pools. You're going to hear from leading folks that actually not only have the knowledge, but actually have like the money, which is really important. So this is sort of part of the challenge. Again, this is a hard thing. We recognize getting this done is going to be difficult, but that's going to be really critical. One thing I also want to emphasize, this is a small detail, but it is critical, is that ARPA-H is the first out buyer of the outcome. In other words, if you are to find others that are saying, look, we would like to supplement that purchasing pool, you have to blow through all that $15 million of ARPA-H incentive before any of that is tapped into. So we think that what that does, it creates an environment where before anybody even pays, like another sort of outcome buyer, they know they're in a situation that's well vetted and is all ready to start to go in the right direction. If there's one thing we've learned in government is that we are the spark that then has to fan the flame, but we have to make sure that that doesn't sort of die right away. So we've taken pains to do that. Anybody coming back to sort of the structure of the program, let's say you go out there, you've got the outcome buyers, you go out and you deliver services. You do all that amazing stuff that you know you need to do and probably are been thinking about for a long time, but you just never had the buyer of the outcome. You ideally move and make that outcome better as time goes on. Over 3 years, you do well for yourself as an organization and everybody wins. I will also point out that the way we've done the economic analyses in terms of the targets we've set up, each of those will generate roughly $60 million of societal value. Meaning if you actually improve, say, serious obstetrical complication rates by 20% in a population, that's $60 million of value. I don't plan. That's not like some crazy quali math that nobody ever believes. This is hard math in terms of healthcare claims, employer costs, and others that you can sort of use to actually show that you're generating value. All that data, by the way, is in our slide decks and in our draft solicitation. In any event, $60 million of value, ARPA-H will advance purchase $15 million. We're asking for 2-to-1 match. So that's $45 million in sort of advanced purchase commitments. That is virtuous. It creates $15 million of value for your community out of you're doing that as a health accelerator. And then think about down the line. You as a health accelerator, over that period of time, maybe you bootstrap, maybe you find at-risk investors who sort of help fund that. Maybe they put in $10, $15 million to help you actually deliver this program, and then you actually could make $45 million. that is also a positive return on investment. So it is a win-win-win all along that line. I want to emphasize, this is not charity. This is actually creating a business case that we hope is sustainable in the long term. Just going to do a quick time check. Got a couple more minutes. So what does this actually do on the ground, right? Like, what does it look like when you start to play soccer instead of basketball? And this is just by way of analogy, what we think about would say a pregnancy journey. So let's sort of, there's a bunch of data up here, but let me just sort of put it in this way. I have experience, I worked as a chief medical officer at a major payer nationally. And I also was executive at the Center for Medicare and Medicaid Services years ago. So I know what goes into some of these decisions that are made when sort of we know what kind of good things are to do, but it has to be balanced against the reality of what the costs are. This is typically how these conversations go when we talk about how we're going to make maternal care better, which is we'll say, oh, this is great. Who are my patients that are seen in this particular geography? I know who they are. That's great. I've got this new app or this new sort of service I'm going to make available to those individuals, and that's going to improve disparities nationwide. That is a reasonable approach, you know, and for the lucky few that actually benefit from that great sort of doula or that incredible access to somebody who cares, they're going to do well, but it doesn't get the structural features. By analogy, when you have a program like Heroes, think about how that shifts the conversation, which is what is it that truly can improve serious obstetrical complications? It is actually, for example, potentially, at least the data suggests, it's maternal perinatal quality care collaboratives. If you're not familiar with that, that's essentially an approach where hospitals get together, they share data, and they share best practices and are held accountable. It is enormously effective, but there's no single customer or to a payer. So I can tell you when I was on the other side of the table, we almost never would invest in that level of strategic societal support. In the Heroes program, that is precisely where you do because it's the most impactful. You can sort of think about that over and over again in the kinds of areas we are looking at. Let me give one other example around opioids. We know, when people who inject drugs use unclean needles, they can get hepatitis C, but what's even can be even more devastating acutely is when a bacteria is injected into the bloodstream. That can cause a condition called acute infective endocarditis, where bacteria get into the heart on the heart valves. People actually can die or require valve replacement cardiac surgery. These are young people. When a team that I was part of years ago looked at individuals who had opioid use disorder, who were admitted to a hospital, had cardiac surgery, which you just think about how much that costs. Less than 25% were actually given medication-assisted treatment afterwards. Whose job is it to fix that problem? So that's the kind of stuff we're talking about. So that is where a program like Heroes, with the creativity and all of you understanding these forces, that is where you create systemic change. So you can think about how would you address that in a large market? What I'll close by saying, at least in this section, is what we're looking for is, not doubling down on the kind of the same old highly expensive individualized care. That's important. Don't get me wrong. But what the Heroes program allows you to think at a population-wide level. So the interventions we believe will be most successful are ones that are broadly making the system better. They are structural solutions. And that's sort of what we're thinking we could potentially deliver through the Heroes program. I just have a time check. I have 5 minutes left, which is perfect. So here you can see how the rewards flow. The Health Accelerator deploys technology engagement, clinical care. Ideally, they impact the health outcome. The Health Accelerator gets funding back from ARPA-H and the other outcome buyers, creating that virtuous cycle. If they don't achieve those outcomes, that is also one is held accountable for that. There's no downside risk, but you just don't get all the funding if you're not successful. So this is the same thing. This is how the market works, right? We pay for things and we incentivize success. We have done a fair amount of modeling. I just want to point this out, not a lot for you to all read here, but this is in our materials. And this is why we're confident that outcome buyers and others hopefully will see the value of what we are generating. This is just one example of the value we're creating around the example I've sort of been talking about, a serious obstetrical complications here. This is what is called a rate card. Again, ton of information here, but for those healthcare nerds among you, we will actually, it is super clear. We set up how much better you're supposed to be compared to the comparison group, the difference in difference, how much you get paid every 6 months. We at ARPA-H will monitor that over time because the Health Accelerator, their job is just to make health better. We will track all that. And then every 6 months, we pay out what is earned. There's no cliff. It's a linear relationship of, bunch of kind of details how we're doing the payment. We're trying to make it as fair as possible. We also be monitoring. So part of what the benefit of being in the program is it Health Accelerator will benefit from sort of tools to monitor success, look at that payout. We'll have a bunch of sort of auditing mechanisms, ways in which you can make sure that ARPA-H, we're holding up our end of the bargain. We'll be having learning collaboratives, communities at least every 6 months, and then tracking markers to sustainability. I only mention this, there's a lot of detail here, but the point is that you will not be walking this path alone. If you were to come on board, you will be part of a national community of innovators that are all working together to make healthcare better, and will make you feel like you're part of that community. What I'll sort of close with is that one of the things I think we've learned in healthcare is that I think there's a quote that every system is designed to get the results it gets. And the system we have, it's working perfectly, delivering what we are incentivizing. The reason we're talking about the HEROES program, and I think one of the reasons that it's been such a, I'm so grateful to Renee, Arti, and others, is that literally no one is coming to save us in this regard. Like, it is just, waiting around is not going to make this problem better. And so you look at sort of where the traditional financing is, traditional payers, public health departments, agencies, venture capital, private equity. They're good people that are working in each of these areas, but structurally the way it's set up is not going to let us improve health at scale. And so the HEROES program, what I'll close with is one of the invitations here is that it is high risk. It is high reward. We may or may not succeed, but the one thing I'll say is that at least it is a sort of a risk worth taking. It's a battle worth fighting. And even if we don't win, if you participate in this, you will be secure in the knowledge that you played a critical part in trying to make the system better. And it's amazing how the things you learn, even in unexpected ways, bear fruit down the line. So success for me looks like us collectively making health all better. We're going to shoot for that. But for the time being, what we just are most excited about is your participation. So with that, I think we're going to close out this section here. And I'm going to hand over to some of my colleagues. So we're going to do like a little bit of a fireside chat, which I'm really, really excited about. Actually, do we have our fireside chat members here? We'll have David, Caroline, and Jake. So I'm going to introduce Dave. I'm just going to put it out there. And we'll have a break after this, by the way. I am like so excited. One of the things that's so great about having this group together is, I'll let David introduce himself, but in many ways, David is one of the critical thinkers in this area for saying, well, how do we actually set up incentives in this really special manner that can have this degree of impact? David has been incredibly influential, not only in my own thinking, but in our country's thinking around how to use outcomes-based financing. So we wanted to start off with sort of a primer with some of our kind of leading lights in this type of financing, because the first question people ask is like, where does the money go? They're going to tell you. David, over to you. Thank you so much.
Thank you very much, Darshak. A really big hand for Darshak. This is an incredible and important innovation. And I know all of us who've been in the paper success field for so long are incredibly excited about potential, the promise here to see so many new faces in the room. This is a fireside chat. I've got multiple messages from people today who really wanted to come, who are caught in a snowstorm from New York to Boston, who hopefully are doing some fireside listening right now. And it's maybe good because the room's pretty full. It'd be standing room only. But hello to everyone at home as well. So pay for success, outcomes-based financing, that's what we're going to talk about today. It is a core part of the DNA of the HEROES program. Pay for Success is the contracting and project design and project assembly approach around which much of HEROES is built. And I have the sincere pleasure of doing so with two of the distinguished leaders and innovators in this movement who have really helped to advance the field in ways that is continuing to evolve, and in which HEROES is the newest evolution. So we'll talk about the fundamentals of pay for success contracting. Many of you we know are new to this, its unique advantages, what's different and exciting about it, some of the players at the table, common challenges that one may face in assembling a transaction like this, and how the field has evolved. I was also asked to share a little bit of the history and context of pay for success and outcomes-based contracting. It really came to existence and has flourished in the social program delivery space, many of which intersect with public health and point to health and public health outcomes, but a range of areas it is applied to. I think social services, education, workforce, pre-K and childcare, housing, homelessness prevention, home visiting services. The list goes on, but that gives you a feel for the sort of sectors, social service sectors in which pay for success has been delivered in a range of ways in the US over the last decade or so. In the US, we spend over $1 trillion a year on those sorts of programs. And the reason that we do this, the reason these programs exist, their purpose is to achieve better outcomes for the people and the families served. However, when it comes to these programs, we rarely look at what those outcomes are. When it comes to how we measure these programs, how we pay for them, we tend to pay for process and compliance over outcomes and impact. Pay for success, outcomes-based funding is a response to this. In its simplest terms, pay for success contracting. Pay for success is performance contracting for the social sector, where performance is real outcomes for people, verifiable, verified outcomes for individuals, families, communities served. We talk about this as an innovation, but performance contracting is nothing new for government. Many in this room are very familiar with value-based payment models in the healthcare space, but across areas, it is routine to do performance contracting in government for infrastructure, vehicle fleets, goods and services, trash delivery, wetland mitigation. The list goes on and on. We contract for the results that we want. So it's nothing new for government. It's entirely for social services delivery in the US. A state agency director who worked in red states and blue states framed this for me. We go on the old model instead, the McDonald's model of billions served. That's what we fund. And not only that, we tightly prescribe how those services should be delivered. So this dampens innovation and creativity in service of results. Also, too often it leaves proven effective innovations on the shelf that could be generating better results. We're going to talk more about that. So enter pay for success. The history and the trajectory of this. Pay for success is a field that really, truly, authentically emerged from the private sector, from social entrepreneurs, in particular, mission-driven social entrepreneurs, social services providers, practitioners in the field who were frustrated by the status quo, philanthropy, and leaders in mission-oriented finance who saw the opportunity to unlock better results. They worked it out. They spread the gospel to the field, to others in philanthropy, and to government. And that's where it landed on my desk at the White House in the Obama administration. I was there in the second term, already was going in the first term. Our mission, the social innovation agenda of the Obama administration, was to find what works and make it work for more people. And it was among the most nonpartisan, bipartisan approaches that we had in our time there. This was the solution we were looking for. We made it a centerpiece of our legislative and administrative agenda, enabled over $100 million in new funding. I got the real delight of getting to meet Darshak through all of that. And we got to think about how we might apply this in a public health context. Here we are today. But they didn't just come here. They came to cities, to counties, to states, blue states and red states, which enthusiasm wasn't universal, but it was universally spread across blue states and red states. Congress was an essential player here. House member and now Senator Todd Young from Indiana, Orrin Hatch, Rob Portman, and many others. Paul Ryan, upon retiring on a major cable news network, was asked what he was most proud of, the three things he was most proud of. And one of the things he named was progress in this area for the federal government to begin to pay for outcomes. The field has continued to innovate, continued to learn, continued to evolve. ARPA-H and HEROES is a monumental innovation for the space. It is the newest and biggest. And so the good news is you're not starting from scratch. There's much to be learned from leaders like Caroline, like Jake, practitioners in the field. And so now what we get to do is learn from them about their experience in the field. So I just want to say these are two. It is hard to be an innovator nationally in communities around the country, and I couldn't be happier to be joining these two folks. As I mentioned, the field really emerged from organizations like theirs, Third Sector, Social Finance, and so we'll all get to learn more now. Now, how are you guys going to set up this fire? I want to see you all both very well. It's really great to be with you both. I should be on mic because there's people at home, right? As you can tell, I don't have problems projecting. So for the two of you, I want to ask, how did you become involved in the field? And what attracted you to it? I'll start with Caroline.
Thanks, Dave, and pleasure to be here and get the kind of gang back together a little bit. Excited to share some of the lessons learned. For me, I was working in community development, and I was with a variety of nonprofits, in particular in the workforce development space, so in human services. And those folks were in two businesses. They were in the businesses of trying to deliver outcomes, improve job placement, improved wages. And then they were in the business of trying to keep the lights on, right? And raise the money in order to do that. And through our work, we asked them, well, who is supporting your work? And they said, oh, philanthropy will help us. They really care not just about, placement in jobs, but the wage. Is it a family sustaining wage? Sometimes we try to sell our services fee for service. I said, well, but what about the government? Doesn't the government care about improving jobs, access to jobs and job outcomes? And I said, no, we don't work with government. I said, well, why not? They said, government can't distinguish between funding programs that deliver a service and funding programs that deliver a result. And, the first time I said that, I was like, oh, that's silly. Like, that just must be you guys. You work with 6, 10, dozens of nonprofit organizations that said, you know what? We don't partner with government because government doesn't care, doesn't fund, doesn't pay us for getting results. They pay who writes the best RFP. They pay who does the best, inputs, activities. They're just not in the business of paying for outcomes. And so as Dave mentioned, after about a dozen times, I said, well, how much money is it anyway? And with over $1 trillion a year, that's when I decided, what would it take to unlock the possibility of public funding to invest in outcomes? Could we find innovative problem solvers, not just problem raisers, because this is not an unknown issue, right? That government doesn't fund outcomes. Could we find some problem solvers who might be willing to try a different approach? And so that's what attracted me to this field, this idea that you could also use something that not a lot of people think about, which is contracting, procurement, resource allocation as sort of a not very sexy, but incredibly important mechanism to deliver $1 trillion of taxpayer money every year. Could you use that point of intersection as a way to think about, could we shift incentives? Could we shift the value to investments in preventive outcomes versus service delivery on the side? And so I was most excited to partner with folks that were curious to use the purchasing power of government to catalyze something different and new in the social outcome space.
Yeah. They're not writing country music songs about procurement.
Not yet.
Maybe they should.
Not yet.
Jake might be the first.
Don't challenge me for that. So nice to be here. Good to see you all. I am not Kirsten Hill, although I've had 3 coffees this morning, so I will do my best impersonation. 10 years ago, I worked at a nonprofit consultancy called the Bridgespan Group, and we worked with lots of some of the just most high impact nonprofits in the country, just incredible organizations. And not only does government not always buy outcomes, what they do buy is cheap, right? In the absence of kind of purchasing for the best possible outcome, the best possible value, what you do instead is you go for the billion served or, dozens served, as the case may be, and you try to do it as inexpensively as possible. And so the kind of feedback mechanism, right, around how do you achieve great outcomes and therefore get bigger doesn't exist in most of the social sector, right? And that kind of brokenness, I think, is what has inspired a lot of the work that I've been doing for the last decade. This kind of fundamental failure, right? That the people who need and who get the services aren't the people who are buying them, create all of these problems in how we kind of structure the social sector. Problems that when we start to kind of raise our gaze toward the horizon, toward the kind of longer term outcomes, we can start to solve, right? And that's part of why I'm so excited to be here today and to talk about this program.
That's a really cool framing. The people who are there again, the people who are receiving the services aren't the ones buying them. Is that how you said it? Yeah. So pay for success is a response to this. You answered this to some degree, but Caroline, why are pay for success models exciting? What problems do we hope they'll solve?
So we, after a decade in this business, we have some sort of, catchphrases for this. One of them is the wrong pockets problem, which Darshak, I think, adequately described for the healthcare sector. But the idea of pay for success of really how can you use either public funding or resource allocation to incentivize outcomes was really, that's the question. Could we solve this wrong pockets problem? Could we solve, in the case of, homelessness, right? Within an area where savings might accrue to different groups of people. Could we use a contracting mechanism to try to bring those multiple groups of people together, align on where is the value, the savings or the perceived value of an outcome? And could you get them to join together in a relationship, in a contract together to solve that kind of wrong pockets problem? Could you do it for programs that are not sort of, right as you're having a negative outcome, you're being incarcerated, you're going into the hospital, but could you use a contract to try to shift towards more preventive services and investments in prevention with the goal of saving costs down the line? And could you do that work to show that it's possible? And then I think the other piece that was most exciting with Pay for Success is, could you expand the group, right, of stakeholders that are interested in this outcome and bring them together in this specific relationship? So just as Darshak was talking about, we're not all NIH researchers. In the social sector, right? Pretty siloed as well, right? Nonprofit service providers, philanthropists, and social service providers. What Pay for Success offered was the opportunity to really bring in other areas of expertise and not only have like an interesting, informative conversation, but to say, wait, is there a role for impact investors? Could we leverage some of the expertise around the modeling for return on investment, around thinking about cash savings and value? Could we learn from these other sectors, not in a hypothetical sense, but in a truly like rolling up our sleeves? What would it take to actually implement a different program? So that was the goal of Pay for Success. And it really, I would say the other piece that was exciting is it very much centered around this concept of the outcome buyer, or could you capture the imagination of those who hold the largest purse strings, right, for funding human services or funding healthcare, and bring them to the table in a way that creates a space for experimentation and innovation to try something different in a contractual process.
Yeah.
One thing I would just build on that with is what I found to be most exciting about these things in the last 10 years is the dynamism of the kind of contracting. And we're talking about contracting, right? It's not sexy, right? And often what we see in contracting is this kind of unidirectional, we set up a thing that we want. We need a certain number of services. People go out, they deliver those services. We make sure they've complied and actually delivered those services. We sign the check. But what we're trying to do is actually something that is more dynamic than that, right? In which instead of first and foremost focusing on compliance relationships, we're actually trying to build adaptive partnerships. That sounds jargony when I say it, but what I mean is, things that are bi-directional, that are dynamic, that are changing with context and changing as we learn along the way, because they're focused on outcomes, right? If, like Darshak was previewing here, we are focused on the thing that matters, then if we have a coalition of actors with different approaches, as they're learning about how, those things are succeeding or not in the world, they can move levers and actually change the way in which they're spending money, the way in which they're spending time, the partners who are at the table, and help to achieve those things, more successfully in that same period, not just, make sure that they're checking the box on compliance.
Yeah. So in a moment, we're going to run through a couple of real world examples. But top line, Jake, how is a traditional Pay for Success financing structured in terms of the people at the table, the things that happen in the abstract, and then I'll ask Caroline to walk through an example that she's.
There's a lot there, and I would say, broadly speaking, all of these things have three big pieces that unify them, right? All of them are focused on these policy relevant or meaningful outcomes. All of them link payment to those outcomes, and they use what I would think of as kind of data enabled or more adaptive governance models that let them, manage those relationships to be more dynamic in the way I was talking about. How they actually get that done can be slightly different in different contexts, right? But I think the core thing is getting the right group or the right team, right? If this is a team sport, getting the right team to the table that is, based in community needs and has kind of community representation and voice at the table. And then making sure that you have a viable theory to getting to the core outcomes that matter, the kind of population health outcomes that we're talking about here, or in other places, the kind of specific outcomes that the outcome buyers have identified. At times, as we've all previewed, there's a problem here, right? If we're looking at multi-year outcomes and we're working often with nonprofits or other kind of delivery providers, there can be a gap between the outcomes that you try to achieve years down the road and the money you need to try to achieve those outcomes. And so at times we fill in part or all of that gap with funder capital, be that philanthropic money, impact investor money, or some combination of those things. And oftentimes, we are engaging with funders who can help fill those gaps, who can actually, align their mission with the mission of the contract and help to kind of overcome that time problem, right? And then they take part of the kind of risk and reward of the Pay for Success contract.
Yeah, service providers aren't sort of famously sitting on piles of cash waiting to deliver things, and and getting paid years later. And so those types of investments from the investor community, from philanthropy, from combinations thereof can be incredibly important. So, and by the way, we have lots of time for questions at the end, but I think it's going to be really elucidating. Just talk about a couple of real or potential world examples. The first thing I think we're going with something that's you've actually done.
Yes.
So, Caroline, pick your example.
So as Dave mentioned, this is Pay for Success has mostly gotten traction in human services. So there have been projects across workforce, homelessness, early childhood across the country. But I'm going to take y'all to Salt Lake County. Anybody from Utah in the audience or maybe online, I think. But Salt Lake County, like many communities across the country, was struggling with both homelessness challenge as well as a recidivism challenge. So specifically Salt Lake County as a potential outcome buyer was asking the question, look, we spend $20-30 million a year across our county services, whether it's in our jails, whether it's in our hospitals, whether it's in our homeless services and shelters. Is there a better way we could spend a portion of that $30 million to get better results and reduce costs further down the line? And so they partnered with us at Third Sector to see if we could help them think about what outcomes would be meaningful for them to reduce their costs. They landed in both reducing recidivism as well as increasing employment. So both like, okay, no more negative outcome, but let's focus on a positive outcome as well. And then also engagement for those who are homeless in mental health services and reduction in their stays in homeless services and shelters. So through that process and through engaging with the community, the outcome buyer of Salt Lake County landed on those outcomes, said, you know what would it take for us to procure for those outcomes as opposed to, providing services in shelter beds or what have you? Could we do a procurement for something different? So we supported in that. They launched that contracting process from the county with a commitment to pay up to $12 million for folks who could reduce and achieve those outcomes across those 4 measures. And some service providers in the community responded and said, you know what, we've actually been waiting for this contract for a long time, county. We would love for you to get in the business of rewarding us for the actual outcomes we receive and for us actually supporting people to get into housing, to get into jobs, as opposed to only staying out of jail or providing a roof over their heads for a night. So 2 providers responded, but they said, look, we cannot wait for this 5-year contract, but we don't have the money to cover the cost of our services and wait for you to pay us for results. Because the county was going to hold back their money and say, we're only going to pay for reductions. So that created, just as Jake was describing, a financing opportunity, a financing need. Really what they needed was kind of a bridge loan, right? Like, we need somebody to give us the money so we can then show that we're getting results and receive those impact payments. And then we'll reimburse those folks. And maybe there'll be an interest payment too. And so that's where this idea of the at-risk investor or the upfront funder comes in. So these nonprofits had direct contracts with the outcome buyer, the county. And then they said, okay, well, now we've got a financing need. So we're going to turn around and have another direct contract, which is really more of a bridge loan with these impact investors. And so Third Sector was instrumental in helping set up that process because these nonprofits had never done that particular type of bridge loan before. But the result was pretty incredible. What we saw, not only, by the numbers, was a reduction 40% in recidivism, increase in 20% in employment using evidence-based interventions, assertive-based community treatment, wraparound services, and others. But we saw a structural change over the 5 years in how Salt Lake County thought about creating responsive services for those experiencing homelessness and for those that were incarcerated. Those 2 agencies came together with human services, with corrections, and kind of across the county to really focus on a new North Star that they had not been doing before, which is how do we meet somebody where they're at with the end goal of employment, of stable housing, as opposed to how do we treat the symptoms of what we are seeing on the street. And so that is one example of how it came to be, and what I think is so exciting about looking forward to what the Heroes program could look like is that, while Salt Lake was very intervention focused and more, deep intervention with individuals, what we saw in this movie, this sort of dynamic contracting process, was, again, the system shifted. All of a sudden, the correction system cared about housing stability and employment, which they did not care about before. And it was part of and contributed to a systems change. This is, 5 or 6 years ago that it started, of really getting the county to care and the county agencies incentivized to care about an outcome that wasn't originally in their purview and that they weren't originally covering for in their costs, but enabled them to make that shift and systems change. And that's what I think is so exciting about the Heroes program, is that now we're in a place in the field where we can center that systems change and that structural change as a core goal of the outcomes-based financing initiative.
Well, I think that's a really great lead into my next question, which is for Jade, which is, so why is the ARPA-H Heroes program particularly innovative? Why is it exciting? Why is it an exciting innovation within the pay for success space? And are there any past pay for success lessons that can inform newer projects like Heroes?
Yes. I mean, this is the single biggest swing in this space that we've seen. It's exciting in any number of ways, but the thing that I'm most excited about here is this is a population health level outcomes based contract. This is a big, ambitious, hairy set of goals, right? And also matched against tremendous amount of flexibility and freedom for communities to figure out how to achieve them. And that combination of things is fascinating and incredibly, incredibly interesting and exciting, right? What it lets you do is the ARPA-H team has actually taken on a lot of the hard work that is involved in setting these contracts up, right? They've defined what are the outcomes that we're going to measure, what are the kind of prices that we're going to associate with those things, and they're going to take on the kind of evaluation and measurement role on behalf of a lot of these jurisdictions. And so that kind of reduces some of the kind of time and effort needed to get these things going. And at the same time, pushes communities toward these very ambitious, needle moving outcomes, right? And that combination of things is remarkable, right? There's nothing else quite like it. That's what I'm most excited about. I'll give you an opportunity in case you want to jump in before.
I think for me, one of the things I mentioned in the Salt Lake example is that the government outcome buyer waited 100% of their payment until they saw results. And what you're seeing and what Darshak shared about the ARPA-H Heroes program is that they're swinging big. This has never been done before. And they are also guaranteeing $2 million for folks that get through and are the healthcare accelerators in the program, because they recognize it's going to take time to build something, to set up something new and to be able to see results. And so for me, that's like particularly exciting evolution for the field, is that the federal government is recognizing they need to be big, they need to be flexible, and they need to put some skin in the game too to help support organizations to really develop interventions that are going to work at the population level. So, thanks.
Love that. In terms of
This has just been an endless problem for the people who are in the public health world. You know it all too well. You know there's solutions that can work, that can make a big difference, that can save resources to our medical system, to society, and there have simply not been the resources there to invest it because the incentives haven't been there. It's incredibly exciting. This genuinely, I think, is the first in the world of its sort to have a population health outcomes-based financing structure. And so, no pressure, you guys.
In terms of lessons, I mean, there are a few that jump to mind when you ask that question. One is, I think Darshak set it up really well with the analogy right at the beginning, right? But it's about the systems, right? And I think when I started talking about it 10 years ago, I was coming out of Bridgespan and I was working with these great nonprofits, and I thought, we got to get these great nonprofits to scale. And I still think that's true to an extent, but especially when we're talking about these big population health goals, and really when we're talking about any of this work at this point, we're talking about building more robust systems. We're building stronger infrastructure in the social sector. We're trying to create partnerships that are meaningful, that are multi-directional, and that can help actually rise up to the level of the challenges that we're seeing. So that'd be kind of lesson one. Is it's about finding your team and making it stronger. Lesson two for me is I feel like I'm already hitting on this a lot, but don't sleep on the governance, on the performance management. Like getting this group together and then enabling them with data and helping to be adaptive. It's where so much of the value is in these kinds of multi-year outcomes-based contracts. And then the third, was a surprise to me at least, is that in much of this work that we've done, need and demand have not been the same, right? There's tremendous amounts of need in lots of the spaces we work in. And despite that, not everyone who is in need of a given program intervention wants it, right? So actually threading the needle between need and demand, actually making sure that we are focused on demand generation and on being responsive to what communities want and need is a pretty important part of this whole work.
I think the only thing that I would add that I feel like the HEROES program has done really well just from a government outcome buyer side is around learning how to be more responsive. So again, as I mentioned in the Salt Lake example, they sat in a room, they decided on the outcomes, and then they did their procurement, and that was it. The conversation was your response. What you're seeing here at Proposers Day and what ARPA-H is inviting all of you in this room to do, as well as at home and on the phone, is to participate in shaping this innovation. And that to me is super exciting because it is an acknowledgement that we need to have all of the players to come in and weigh in on what is it going to take to be able to develop an ROI for other outcome buyers to come into the mix? What is it going to take for us to pull together a community with the teams with responsive services along each of these 4 different outcome goals? And so that's really exciting to me that there's not going to be a, drop of an RFP after this meeting, but there's an opportunity for you to weigh in on the draft solicitation. There's an opportunity to come in with the letters of interest and to really, truly engage in improving what this big bet could look like. So that's super exciting to see as an evolution in the field too.
Yeah. So, yes, got it.
I'll be the mic runner.
Okay, excellent. So we're at 10:27. Okay. So shall we start with questions right now? Or shall we have our dear friend Jake walk through an illustrative example of ARPA?
Happy to do that. I think Darshak did a great job here. So I will do the kind of quick version because I'm getting the eye. I think there are a handful of things that I think are great opportunities here in an illustrative example. I think the first job is get your team together, right? Find the folks who can be responsible for these outcomes and who have strong connections into the community, can kind of be responsive and listen to folks who will be engaged through the programs, through the HEROES kind of funding. Part 2 is think through your big bets, right? Where are the kind of great opportunities in your community to make an impact on the outcomes you've identified? And then how do you enable those things with the right kind of technology and infrastructure so that you know if you're making progress and can help kind of accelerate that progress faster? Part 3, not a surprise at this point, it's like a refrain for me, is get together the kind of performance management function, get the table of folks that will be looking at data really regularly and making changes so that you can be responsive and dynamic and can be listening to people, consumers of these programs and interventions in ways that are really meaningful. And one thing we haven't talked about, but I think is really important here and is in the draft solicitation, is make sure that the sustainability partners are at the table early and often, right? This is a moment to test things, but in 5 years, the moment will be, how do we sustain the things that are working, right? So make sure that the kind of sustainability partners are at that kind of performance management table, that they are not just kind of contributing up front, but also the things that we're measuring and that we are kind of monitoring are things that are meaningful for them and they actually take on as a part of their own business models.
Sounds like the start of a country music song to me, Jay. Okay, we are now going to do the next fun part. I was about to say the fun part. That was fun. Now we get to talk to all of you, and in particular, answer any questions you may have. We will start with this wonderful person right here.
Thanks so much. My question is, how are you, or what have you seen work to engage small and medium businesses, both on the employer side and on the care delivery side, in these kinds of conversations? What are they looking for as outcome buyers, right? On that small and medium business side, especially the self-insured. I like to think of them as the unaffiliateds out there, right? For all of us. And again, as participants in delivery, where, you know, our systems are amazing. Many of them I hope are here, but I'm guessing the folks that aren't here are those small and medium FQHCs, clinics, you know, critical access hospitals, right? Like, how do they maybe participate?
Yeah.
Sorry. Kim Lynch, CEO, Metis Health Technologies.
I have some thoughts on that, but yeah. So I'm gonna address the last part of your question, and I'll let these guys think about the first part. So it's incredibly important. One thing we engaged in the Obama administration was something called the Federal Grantee Experience Initiative, where we asked what it's like to be a medium or small size deliverer of service. We talked to FQHCs among many others, and it's a bit of an indictment of process compliance. Fill this out in triplicate. You know, these people. I mean, I think one of the greatest opportunities about Pay for Success is it's about better honoring the work of the wonderful people who are on the front lines doing the really hard, really stressful work every day. And they are asked to, you know, respond to a 70-page RFQ, and they are asked to affirm that they delivered precisely this intervention. They are called upon in their contract to deliver intervention A or B. And if someone shows up at their doorstep who needs intervention C, you have a choice between giving them what they don't need and sending them off somewhere, and you don't know what's going to happen to them. It's spirit breaking. And I think one of the things that's incredibly exciting about Pay for Success is we say, we're going to honor your work. You're trying to get better outcomes for people. We're going to give you the freedom and the creativity to respond to people, meet them where they are, and drive to really important outcomes. And so I think the natural reaction to small and medium service delivery responses can be one of skepticism, and they're nervous. This is the devil they know, right? The system as it is. Now we're asking them to jump through all these different hoops, and we're not necessarily taking a lot of the old obligations off the table until we totally transform social services delivery. So I think it's a fantastic question, and my best answer to you is to bring them to the table and give them the service. I mean, give them the, you know, respect that they deserve for being the ones out front. Help show that you see them and have them be authentic partners in project design, and really think through, all right, can we really do this? If not, how might we do it differently?
I love that, Dave. The one compliment addition I'd add is bring them to the table, engage them, but also be mindful of the burden that engagement can place on small and medium-sized organizations. And so as you all are thinking about who do we engage in our geographies, who matters, making sure that folks have the opportunity to both come to the table, but they're not necessarily responsible for responding or, you know, doing that heavy lift, making sure that their perspective is included, but also leaning on, you know, at a population health level, there may be multiple FQHCs or others that are involved. So are there, thinking about in your community context, are there natural places where those groups go to either get information, to provide association groups or what have you, that can be part of a broader coalition where you can both ensure that you're getting their feedback, their core implementation partners, but you're also mitigating the burden of trying to place all of that population health outcome on a group that maybe serves only one community there.
That's great. And I'll repeat a refrain that Jake has used about the collaboration. Create a safe space. Once you've done your underwriting, you know the partners you're working with, it has to be okay to fail. It has to be okay for your partners to surface warning signals. You should ask them, if this goes wrong, where will it go wrong and why? and you're all in it together to get the outcomes. And that's one of the really cool things about Pay for Success, I think, is that you really are a team driving for results together to support one another. Yes.
Thanks very much. Great presentation. David Newman Toker, Johns Hopkins. I run the Center for Diagnostic Excellence at the Armstrong Institute. My question to you is about outcomes and choosing the right outcomes, because there's some complexity to that issue, and which I'm sure you deal with all the time. At some level, you talk, for example, about the recidivism and the homelessness. You could say, all right, well, I'm interested in the outcome that they chose, which is to get people back into homes and off the street. You could also say the outcome is that they're going to stay in a stable home for the next 5 years or 10 years. Or you could say that they're going to be economically productive and it's going to increase the total GDP of our region or the country. And somewhere between a total process oriented outcome and a ultimate sort of financial gain, pay for success outcome is the space where you have to move this towards, right? Like, could you just talk a little bit about how you, along that continuum, think about the problem, and then talk about how the different kinds of outcomes interact. So, for example, in the diagnostic space, we might say, okay, look, we want better outcomes for stroke based on early diagnosis and early secondary prevention. But we might also be interested in decreasing the cost of unnecessary imaging. How do we combine those outcomes together to get that extra interest and bang in the pay for success space? I'd love to hear your thoughts.
Really great question. And this is sort of the work of the work. I will start by saying first, like, there is no universal perfect outcome, right? And you kind of got to that. What we discovered through our pay for success work over the past decade is what is going to be the basket of indicators and proximate and then leading outcomes and ultimate outcomes that is going to motivate, incentivize this particular community to focus on, the ultimate piece, which is moving from compliance status quo to something that is more investment in preventive outcomes. And so I will say that just, within the homelessness and recidivism space, there was a whole suite. Not every community chose the same indicators and outcome goals. And it was a process that took, honestly, engaging the specific team on the ground around what are the challenges that you're facing in the community? What would you need to see in order to show an indicator of progress that someone is moving from being homeless on the street to a thriving life? What does that mean for you in Salt Lake City and county? And that looks a little different than in LA or than in other places. So that is the first thing. The second, I would say that it is important, and ARPA-H in the solicitation, you'll see it's important to articulate the North Star goal of what we are looking to do, right? So this overall shift from, treatment in hospital care beds to actual preventive health is the overall North Star shift, and that you have clear end outcome metrics, but then also proximate indicators. What we have found also is it's really dependent by project and context, how you think about pricing those different indicators, because as soon as there's indicators that are for learning and improvement, that can be really helpful. And then sometimes as soon as you put a price on something, then all of a sudden it's only about that thing and it's less about the learning. And so that would be one sort of piece of advice that I would have to groups is, as you are thinking about pulling together your coalitions, ARPA-H is inspired by the pricing of the ultimate outcome, but thinking about how you both track interim indicators to learn and improve. That we have found is the most important thing versus pricing particular interim indicators, which can sometimes lead to a focus on achievement, but less on the overall systems changes that might need to happen to get past that to those end term outcomes. Jake, what would you?
I almost don't want to spend. I would love to talk about this. Caroline and I do this constantly, and it's been a huge part of the work, and it's custom and hard, as you might imagine. And also, the ARPA-H team has done a lot of this work for us in this case. which is great. And also, to Caroline's point, it still leaves a lot of kind of white space in the performance management arena. Like, how do you actually think about tracking toward these ultimate indicators? How do you know that you're making progress? Where are there kind of warning signs and where are there kind of green lights? Which I think is both art and science, but it's being responsive to community needs, being thoughtful about the kind of time period and the data access in your kind of outcome and interim outcome metrics, and then the kind of periods in which you can make careful measurement tend to be important things we look at in that process.
It's coming. You're talking about, in a way, some cost saving procedural stuff, reducing scanning while getting better outcomes, more scanning. If you scanned everybody, you get better outcomes. You can't afford it. So I think something that's really fascinating, exciting about this is it's opening up some new opportunities to test things in new ways that you otherwise wouldn't really have the opportunity to do. And there's some kind of additional legends of the field here in the audience. I see John Grossman and Andy Phillips and Andy McMahon. And I know that some of them have talked to ARPA-H about the real need to be flexible and work with the accelerators to hone in on some of these problems, to really grapple with them, understand them, and be flexible, which I think is a real strength. Really firm, let's set it at the beginning and look 10 years later whether we achieve the outcomes is not going to be as responsive to community needs. So really excited about that flexibility. Yes.
Thank you. Esther Dyson from Wellville, which, spoiler alert, started as a 5-year project and is now a 10-year project ending this year. And so the question is more of a prompt. 3 years is great for some things, but some of the most impactful stuff actually takes 10 or 20 years. And just very specifically, the maternal health thing is probably going to reduce opioid overdoses 20 years from now. Whereas actually reducing opioid overdoses is right at the end. And so it's a hope that this thing will be incredibly successful. And then you'll do it with 10-year time horizons and so forth.
I mean, I
Couldn't agree with you more.
Yeah.
Yeah, clearly true.
And I think maybe just to connect back to the other data question, I think one of the opportunities with this project and this program is to explore what are those indicators that we might track that are proximate, but what are the indicators that we might track that go beyond the 3 years? And, the idea of bringing in additional outcome buyers to support sustainability could be, what do those outcome buyers need to see in terms of tracking? Let's be real, like, what do they need to see in terms of cost savings? What do they want to see in terms of other outcome indicators? How might your project or the health accelerators think about tracking items and indicators for learning and improvement that could be very proximate, could also be a little bit longer than that 3-year time frame, to incentivize, again, this overall shift that we're trying to focus on for preventive health outcomes.
That was emailed in from our virtual audience members. I'll just say after this, we will have a 10-minute break and we'll ask people to please be back here. We're going to start at 11 a.m. sharp. We're really trying to stay on schedule to respect people's calendars today. But the question from online is for the group, what are the most important differences in outcomes based on financing between healthcare and other social sectors with health accelerators should know about?
I want to answer that slightly differently than the way that was asked, which is I want to think about it for this program, right? Rather than healthcare as a field, which is, a third of the economy. It's big, and this program is big too, but it's also remarkable and divergent from some of the other programs we worked on in that we're talking about populations, right? Which isn't what we have generally talked about, right? We've often talked about, I've been working for 6 years in Anchorage on a homelessness project in which we are talking about a population of 160 people, right? Which is meaningful, and it's been important, hard work. And this isn't that. This is populations of 500,000 or 1 million or 2 million people, right? And because of that, I think it requires of us a different set of actions and a different set of expectations, right? Those actions have to be the way I started this panel of big swings. So they have to be things that can make really meaningful change in these large scale health outcomes. And they require us to do those things quickly, right? And to change course and actually to make multiple investments simultaneously, because no one intervention, no one program is likely to achieve some of these, really ambitious population health goals. And so what we need to do is think about what are the kind of suite of things that we're going to pursue with this substantial but still limited funding. And how do we make sure that we're making progress on each of those things? And when some are making more progress than others, how do we double down on what's working, make sure it gets to more people and that it's adaptive when it does, while at the same time, not just, spreading like peanut butter, the things that we think are going to work broadly over a community. So, that's not exactly a health versus social services answer, but it is a population scale versus individual scale answer.
I love that. Moving from an idea of a complex system intervention as opposed to a single point in time intervention. I would say the other aspect of health that I think is just more pronounced than other areas of the social sector is the cost implication. I mean, that is a very well established, enormous business in this country around the cost of delivery for certain healthcare services and programs. And I think that that's something that there's a real opportunity to engage with in this program around what is the ROI if you avoid certain hospital treatments, but what could we think about would be more of a positive ROI for investing in prevention? Could we sort of expand the thinking and the zone of what's possible on this idea of valuing a particular outcome? We're very good at valuing the specific healthcare service you might receive. This is an opportunity to, if you get the right folks in the room, to think about what would it take to value and put an ROI on these more preventative outcomes, because we know that no one else is coming to save us if we don't take this opportunity, this space to think about it and potentially also to test that. So that's, I think, one other difference.
It's incredibly exciting. Darshak, thank you for the opportunity for us Pay for Success nerds to get to share a little bit with you about this field. We are so excited about what you will dream up and pursue.
But please thank me. Please join me in thanking this panel. We're going to go ahead and get started. I'm so excited. I'm going to let my great friend Kavita Patel introduce herself in the panel.
This is going to be a very unconventional panel for a very unconventional program. So I think it's fitting. And in full disclosure, like none of us actually coordinated our answers, which might actually make for a more entertaining, or the questions. We weren't entirely sure what we were supposed to talk about, but that's okay. No, in all seriousness, this started from a conversation that I think several of the kind of ARPA-H team had, I think, with us as individuals kind of talking about a question. So I'll start and kick off. I'm going to ask my co-panelists, whom I have the benefit of knowing 2 out of the 3 of them all too well, but I'm going to ask them to each kind of just introduce themselves. I'll give their name and their title. You have their bios. The older we get, the longer our bios are. So I try not to read bios. It kind of feels like I could never do them justice. But I'm going to ask each one of them when they introduce themselves and kind of why we think we're here, to also answer kind of a question about how important we all talk about population health. And I think all 4 of us probably have dedicated our lives to population health in different ways. But like, why is now kind of an important time, this program, this opportunity, and kind of what population health means, when we think about 2024 and all the conversations we're having, value-based care, AI, the deployment of capital for a lot of companies. Billions and billions of dollars will go out this year for health technology, for health outcomes related companies. Where does population health for each of you kind of fit into, where we are today and what you're excited about? Or you can just answer whatever else you want. I don't care. But it thought it would be a good way, since I think all 4 of us have kind of maybe similar, but some different takes on that. So I'm Kavita Patel. I'm a professor at Stanford, based here in DC. So there's a Stanford in DC theoretically. And I also spent time as a venture partner at New Enterprise Associates, which is a large venture firm. And for me, when Darshak and I were speaking about just this opportunity, I said to him, I said, I've dedicated my life. I'm a primary care physician. And I said, I've dedicated my life to population health, but nobody gave a shit about it before. And so it feels like now that people can make money off of it, it feels like we care about it. So I said, so how do I think about the business of population health? And that was actually what started and sparked this conversation, because I felt like for me, a lot of it has been a lifelong journey, and it's a lifelong journey of success, feeling really great about moments of population kind of tackling kind of hard problems, diabetes, obesity, depression. But then it also feels like sometimes failure. And I don't think failure is a bad word in this. I think failure is where we learn and iterate and try to do better, do better, do better. And for me, the kind of concept of being here with population health at this moment is, how can we bring those worlds together? Bring like kind of the clinical world of people who are just sometimes feeling like they're pushing a rock up a hill, and then bring together this, I'll frankly call it a business opportunity, because as I've spent time in venture, we've had to make the business case. We couldn't really say, let's invest in X, Y, and Z, maternal kind of outcomes related company without having a business case. And then third, and kind of, I would say the most important is, how does it affect the people? We call them consumers, patients, they're all people. So how does it affect the people? So that's my kind of take and biases. And next to me, Vishal Agarwal, who's one of the senior vice presidents at Humana. And also, we didn't try to stack the deck with clinicians, but it just so happens that a lot of us happen to have attended medical school and have identified ourselves in that manner. So I'll be curious how you answer this question. What does population health mean for you in this moment?
Oh, thanks, Kavita. Really great to be here. And Darshak, thanks for the opportunity. So my background, while I'm a physician, I never practiced. I was always in the business side of healthcare, and kind of seen a lot of different parts of the system. I was a management consultant for a while. I'm in the private equity world, and most recently I'm at Humana, lead strategy and corp dev there. One of the things, though, back to the pop health question, is just recognizing that the system gets the results that the incentives are set up to deliver. And when Darshak and I had dinner a couple of times, just hearing about what ARPA-H is trying to do and get to the fundamental upstream, how do we actually change the incentives so we can drive better outcomes? That, I think, it's powerful. It's what we need. So much of our waste in the system, and I know Will Schrank is sort of the expert in writing about waste in the system, in the health system. He has, and hopefully you'll talk about that. But I think that there's a real opportunity out there to go after that. And the way to do it is with a more systems approach, with innovators, government, with industry players to coordinate on what is the outcome that we're looking for. What are we trying to achieve? And then how do we move upstream to create the right incentives, to create the right interventions, to drive out the waste and deliver the outcome? So excited to be part of the journey, and looking forward to the conversation this morning.
I love it. When Darshak first told me this, I thought he was crazy. And I literally said, like, are you for real? This isn't something. We've shared lives in the government in the past. And I said, will they let you do this? And once he said, yeah, I went through clearance and all signs are for, green light. I said, that's incredible. So I will say it was like a moment, like, are you serious about this? And if you are, like, I'm on board. So, all right. So next, Andy Phillips, I realized for Vishal, I didn't read his proper, I think when I met you, maybe you've been promoted. So, or at least I had always kind of not read your proper title. So I will give credit. Chief Strategy and Corporate Development Officer at Humana. It's a bigger job than I had given him originally. So Andy Phillips, co-founder and managing partner for the Community Outcomes Fund for Macomb Capital. Didn't want to neglect the titles that we've all appropriately earned. Andy, how do you kind of answer and just describe kind of what you do, what Macomb Capital does, and then how you kind of see this population health, the conversations from this morning, and what that means for you kind of in this moment of time?
Right. Thank you. So I am the non-doctor on the panel, neither academically nor practicing, though I am a consumer of healthcare. I first talked to Darshak about the germ of this idea probably over 10 years ago. I think at that point I was still at Goldman Sachs, where I had the great honor of investing there and their clients' money in projects like we're talking about today. I was so taken with the potential impact and the role that private capital can have in sort of driving this both change on the ground in communities, but also really a change in how the work gets done. I was so taken with it that I actually quit my job at Goldman Sachs and launched Make Home Capital, where I've put together a pool of capital and investment fund that is really focused on projects like we're talking about today. So we've been sort of quietly working in communities across the US. When you look at the balance sheets that folks control who are sitting on this panel, take off 2 zeros, possibly 3 zeros to get to where I am. What I will say is I'm not sure that matters, though it is fun to sit on a panel with folks like these. And so we have deployed around $50 million really towards driving change in communities, the pay for success financing, or what we would call outcomes financing that people are talking about. I am going to talk about a project that focuses on maternal health in Spartanburg, South Carolina, that we have financed. And it both looks at interim outcomes in terms of impact on families, as well as really looking at population health improvements. And so, just to be a little bit didactic, how it works is we provided a working capital loan to the lead partner in Spartanburg. They are working with a group of service providers, hospitals, community leaders to make sure that they are doing this systematic approach that this RFP or this project asks for. Where is Esther Dyson? There is Esther Dyson, who gets a shout out for actually being the person and her team on the ground in Spartanburg that was really a thought leader in this and getting this off the ground. So what do? We provide a flexible loan to all those project partners so that they can hire and train the community doulas, the home visitors, the caregiver trainers, all of the folks on the ground who are doing the work. Our payment is exactly as this is structured. It's based on as they over time hit the predetermined outcomes. I'm happy to report that we're having incredible success both on the ground, which means great impact in the community writ large, but also on individuals in that community. What that means for our investors is that this is financially successful as well. We still got a couple more years on the project, but we're really excited about it. And so I think part of why I share that example is to say there are places where this approach is working. What is incredibly validating about today is the idea that we are sort of elevating it, that the federal government is at the table and saying, this is the way this work should be done. And so it's really, really exciting to be here and look forward to continuing the conversation and talking a little bit more about how we see our role as an investor in these types of projects.
I suspect if people haven't already, they're going to make a beeline to you to try to get a lot more information. So maybe if we can, we'll dig more into lessons you've learned. Last but never least, Will Schrank, my friend, who is a venture partner at A16Z. There's like technically a title for that too, which it's just A16Z. All right. I thought you were bio and health, A16Z, but formerly chief medical officer at Humana. So I think when Andrew was talking about the 000, it was from that aspect. So it's, Will, since you and you also have your former kind of government days as well, sitting on the federal side. So tell us kind of how you think, and especially kind of in context of knowing how hard it is to kind of get some of these things across some of the different transoms, whether it's venture, payer, very large payer like Medicare. What does population health mean in this time for you?
Well, thank you, Kavita. And just a warning, Andy, I think you're at risk here because I've worked with both of these folks and you might be next. One of the advantages of not being able to hold, and I worked with Darshak at CMMI, one of the advantages of not being able to hold down a job is you get
Work with
to,
you at some point in time. That's right.
you do get to see sort of, well, I've had the good fortune to see the challenges of implementing broader population health strategies from a variety of seats. And there are real challenges from every single seat.
Mhm.
And I think this idea of having a market-based approach with alignment around outcomes that brings everybody together is the most novel and I think creative and the greatest possibility of being successful of any of the stuff that I've participated in. I'd also say one thing that might be useful just to say out loud that I think is implicit in the four topics that were selected here and the kinds of folks that are participating in this meeting and that are going to be accelerators and are going to be doing the work is that the outcomes are all health outcomes, but underlying those health outcomes is social context. And none of these outcomes can be addressed holistically, thoughtfully, without sort of getting deeper into the sort of the context in which people live. We as a healthcare system are wildly over-indexed on paying for our health outcomes and under-indexed on paying for social needs. And this is a beautiful, beautiful way of creating better alignment and really a better focus on what the true causes are of worse health outcomes. So I am super fired up about what folks in this room, Darshak, what you guys are doing, and eager to find ways that we can all be helpful.
He's going to need that help. So let's get to some of the challenges that'll create the context for needing that help. So I'm going to ask each of you to kind of, it's not a role play because you've each had to do it. Kind of each of you, as you're thinking about bringing this to a larger, let's say it might be your executive committee, might be your investment committee, might be some entity, might be your LPs, might be some group of people who are incredibly motivated stakeholders to at least have a say in how you might come in with funding of any size, any amount to kind of be a part of what I would say this, I'll call it a partnership. I don't know if that's the right way to identify this, but you're coming in as a meaningful investment partner with four clear, I don't think you could find a more unanimous panel that this is the right thing to spend time and money on. And then we have to kind of put together in our different roles, I don't want to call it the kind of defense, but you have to put the justification together for why you think this is worth. And again, let's fill in any dollar amount that's of significance to your executive committee or stakeholders. How would you think about justifying this? Or how would you identify some of those challenges up front and ways you might mitigate that? And I think each of us probably have different ways we have to do that. I'm trying not to, I tend to kind of lean in this way. It's like where I carried my kids on my hip, I think. And so I don't turn this way, which is, should have put them on this side sometimes. But so I'll try to make sure I get this side, and we'll try to leave some time for questions. But while everybody was thinking, and maybe I'll start with you, Will, kind of thinking about when you're presenting some of the challenges, how you would kind of put together like that justification so that you could bring forward. And just again, this was full disclosure when Darshak and I were speaking, it was in these challenges, in these experience with our prior like roles with failures that we've personally experienced and trying to deploy, value-based programs, different models for innovation. That we've got some of those scars. So Will, how would you think about facing an investment committee, executive committee, et cetera, and putting together what I think is an incredibly creative program, but one that's not familiar to others? This will be novel. And maybe with the exception of Andy, most of us have not brought something forward like that for an investment.
Yeah, it's true. So, I think actually the experience that Vishal and I have had speak directly to some of the challenges of investing in a venture-backed startup that ultimately has to look for ways to find scale in the marketplace, and generally wants to do so by partnering with a Humana.
The good news is that Humana is trying to achieve many of these outcomes that are aligned with what's right for patients and what's right for society. But the challenge for a startup is that Humana is a huge company that has very specific products that they're trying their outcomes that they're trying to produce are very specific and really drive financial as well as health performance. It's a hard way to kind of just build your company, particularly if you're trying to do it with a couple different payers. The idea of having alignment in a market and essentially a laboratory to do all the right things, not be like totally beholden to a specific customer, if you will, but be able to kind of think much more holistically about a population, about a region. I mean, it's what Humana can do only in places where Humana has a huge amount of market share. And sadly, we don't really have like that kind of concentration. Well, I don't know if sadly, but that kind of concentration doesn't exist for the most part. This is really the geographic nature of this is so novel that it really allows a startup to innovate and learn. Because it's not like you flip a switch and suddenly the startup that's focusing on maternal health is going to fix maternal health. They got to get out there in the field and they got to figure it out. I think this sort of model allows for time, flexibility, and frankly, not a different, sort of customer that you're beholden to, or a variety of customers you're beholden to really focus on what's going to drive those outcomes and what's going to produce, better healthcare for America.
Andy?
Sure. So as you correctly pointed out, this is not new to my investment committee. This is our bread and butter and what we do. Our investments are typically structured as flexible impact aligned debt. What that means is we're lending money to the health accelerator to fund the partners to do their piece of it. And that means it may be a venture-backed startup that is providing some critical piece of the work that's happening on the ground. It may be, as the case with our Spartanburg example, a group of community doulas that are literally doing visits to at-risk moms. And on the Spartanburg note, I do want to give a shout out to the Institute for Child Success, who is our lead partner on the ground for that project, who I believe is out there on the phone. So shout out to them for all of their really amazing work. And so like I said, our investment committee is used to this. When we think about what do we care about and what are we looking at when we make an investment, where we start is the impact and the outcomes and really understanding what is the strategy on the ground. And if that strategy is implemented, is it likely to result in the population-based outcomes that we're talking about? I think the advantage of this approach is that it is not, the expectation is that folks on the ground can be nimble. So we're not being very restrictive on the uses of our funds, but really what is the overall strategy? And literally working with our partners to say, what are all the pieces that are going to work together on the ground that are going to add up to that population level shift? And so we spend a lot of time there looking at research, evidence-based practices, track record of the different partners in those particular communities. We then also spend as much time focused on who the partners are, who's the lead partner, right? I think you heard from the prior panel that this is all about collaboration on the ground. It is all about performance management, because the one thing we know for sure is whatever happens once we launch, there's going to be a bump in the road. And it is really all about what do we do when there's that bump in the road? One of the projects we financed early on was high quality pre-K in the education space. And then COVID hit. And we had to figure out with our partners on the ground, how do you deliver pre-K during a global pandemic? The good news is we figured it out and we made game-changing impacts in terms of kindergarten readiness on our students. The same is going to be true here. There are going to be things on the ground that we don't know until we know them. And then it is really about the strength of the partnership, the mechanisms for performance management to tweak what you're doing on the ground. And then finally, we do a financial analysis. We really look at what are the projected cash flows if things go well. What are the projected cash flows if things go less well? And really try and work very hard to structure around that risk. So that really, we would look at one of these investments in really the same way we look at all of our investments.
Michelle.
I'm trying to think what would be additive. So a couple of thoughts. When we look at investments, we're not just looking at the financing. We're trying to think, certainly financing is a part of that. And this mechanism is phenomenal for project financing in a community. But it's the sort of the next step of how do we make sure that the solution is working? And do we have the data to help rapidly iterate that solution so that the innovator can move as fast as possible? And that's often an issue in healthcare where you don't know the outcome for a year or two or three, and by that time you run out of money. I think some partnerships, particularly with organizations that manage larger populations, can be very useful in providing that data. I know, Kavita, we've looked at it with assets that the NEA has had, and in the kidney care space and other areas where we can rapidly innovate with the innovator. And then I think it's then thinking through the scale up, because often healthcare is so local, and there's local market dynamics that often come into play. And so it's really thinking not just the financing, but the iteration model, and then how do you scale it so that it can be applicable to more and more populations and more geographies. In terms of then, when we do make an investment, it isn't a blank check. It is there's stage gates, like any often venture investment often entails. So it starts off with often patient engagement. Does the solution or intervention, is it being used by people at a rate that's beyond just noise or control or placebo? And that's the first step, really looking at patient engagement. Once you feel like you have patient engagement, the next step is, can you measure some reduction in waste in the system? Getting back to that theme, and it could be in this case, in those four areas, the prevention of stroke or heart attack reduces ER visits per 1,000 or reduces hospitalizations. That then creates some value that can be redistributed back to the innovators, back to other participants in the system. And so once you have the engagement, we really look for identifying demonstrable reduction in waste in the system. And once we have that, it's really then getting back to the scale up. Can we take the solution? Does it then scale to more populations and more markets? And so we would set up in a typical venture investment stage gates for the organization. We run A/B tests quite often, and we'd be looking to see are we hitting those interim milestones? Are we getting the engagement? Are there indicators of removing waste? Do we have conviction that, or at least some belief that this can scale to more and more places? And the funding would come alongside each of those gates being cleared.
Just to jump in, can I make this more of a conversation? I look to our fearless moderator. Is that okay? I think the points you're making are great, and I want to just underscore them. So when I think about the opportunity here, there is going to be opportunities for venture-backed firms to be part of these collaboratives on the ground, maybe even leading these collaboratives. What I would echo is that when we think about our financing, it is also about what are those first indicators? What are those early indicators that we're heading on the pathway that we're heading to? and, sort of walk before you run. Can you target a particular population and then begin to scale up? And that's something we also pay a ton of attention to and tranche out our financing to be aligned with that. What we have also found that I think is an important lesson from some of the outcomes financing and pay for success work that has already been done is that in some sense that creates a virtuous circle. Because what you are doing is keeping everybody at the table, keeping everybody problem solving. And I think where we diverge from sort of more of a typical venture investment or sort of the venture approach is that folks are aligned more around the social impact. And so there is sort of I would say a slightly different table stakes to bringing everybody together. But really, there's a lot of this that is fundamentally the same. That said, I think the other hard-learned lesson we've had in this space over the last 10 years is that in most cases, flexible debt is a better fit. It is cheap and cheerful, easy to manage, and given the scale of these contracts that they're not sort of 10x upside, it is often a much better match.
So I'll just build on, I think your point is really, really good. And actually off both of your points, I think there is a path for a venture-backed startup to be incredibly, incredibly valuable in this scenario. In part because the nature of the contract here is different than that sort of very execution oriented. I've got to get this amount of engagement. I've got to get this amount of early outcomes, which doesn't necessarily encourage like the kinds of partnerships and team approach that you really need to solve some of these really intractable healthcare problems in society. And by just saying we're going to give you some space, we're going to pay you on an outcome, and we're going to give you a whole different kind of flexibility, a flexibility to decide who you work with, try to better define what the problems are you're trying to solve that are the sort of the key drivers of those outcomes. That level of flexibility, I think, is going to create more innovation in the marketplace and definitely different kinds of partnerships. It's a little less execution oriented. And I think we're all sort of in the business of execution orientation. This flexibility, I think, is, it's going to be an awesome experiment to see if that creates the right kinds of partnerships that allow for a much more holistic view of how you drive the outcomes we're trying to produce.
I don't think we would have gotten here without having all these kind of iterations, even state innovation models, bundled payments, all these, even patient-centered medical homes, ACOs, like in a way sad as it is, it's kind of been all throughout like my adulthood that we've been iterating over this, but we had to do it that way in order, I think, to get here. I don't think we could have just said, sure, you've got billions of dollars. Let's just go ahead and give it to a community without going through and trying to think about different economic incentives, to your point, to, seeing what works with the community and what might not work. I know we want to give time for questions, right? Darshak? Okay, good. I want to do maybe one. I'm going to push us a little bit. And the only thing I'm going to add, so I'm going to say the question and then answer the question I asked myself and then start the new round of questions. So I can give them time to think. We didn't try to like have a preset. We had some thoughts and questions, but as a great moderator, I've avoided all of them and have completely sprung new questions on them. Each of you have talked about you've alluded and then directly spoken to kind of challenges, lessons learned. Try to just kind of highlight, because we've got a room of innovators and people who really want to make this work. Just some things that you've learned along the way that might be beneficial to give voice to. Sometimes it's stating the obvious, bring the community to the table. That might seem very obvious, but things like that sometimes get lost when you're reading RFPs and you're trying to answer all the, kind of what's and whys. And so I'll offer an answer. So you all are thinking about that. I'll offer kind of my only when I was looking at some of the different aspects of the Heroes program, I thought quarterly report, that's not enough. Like we need to have like, it's not because that's how investors think. It's just, that's how people, it speaks to kind of something Vishal said, like, it's got to be this like cycle where there's data, transparency around the data, and kind of a humility around the data. Like if things are not working, doesn't mean you're failing, but it does mean that you need to probably take a step back and think about, have we been framing the approach wrong? Have we had the right partners at the table? Have we thought about the actual data collection in the right way? Sometimes we are so married to a certain type of data collection that we're not actually broadening the perspective of what can have an impact to people. And then I like to kind of bring it back, even with early stage companies or companies that are public and are, billions of dollars, it's always about people. So very rarely do I say, well, that was the waterfall or the spreadsheet that caused all the failures. It's not failure or success without thinking about the people. And one of the hardest lessons, and now I'll answer my own questions. One of the hardest lessons I've learned is kind of when you don't have the right people, being able to kind of say, like, I need to get the team. And it's different in different settings, but anytime I have had a thought, like, do I have the right person or team or partners at the table? The minute I've asked myself that question in my mind, I know that it's already too late. And to some degree, I've probably always had an inclination that this was not the right team, the right partner. By the way, that includes myself being one of those people. So I think it's critically important to constantly think about the people. And I'm also a big believer, it might not be popular, so I'm just putting it out here. One lesson I've learned is I was very nice about it like 7 years ago when I started kind of working on investment deals, but now I kind of fundamentally require it that you have some sort of like human-centered design kind of at the initiation, that there needs to be an intentional thinking. Just because you might be the world's expert in maternal health does not mean that you understand what it looks like in fill in the blank, Spartanburg, South Carolina, or wherever you're trying to engage a community. So I've now, as I get older, I can just tell people what to do and sometimes they listen. And so now I kind of insist, like, have we talked about the kind of human-centered design approach to what we're offering in terms of a partnership with a health plan or working with physicians to try to stem chronic kidney disease or any number of efforts. So those are some of my lessons and ways that I've tried to translate that. Vishal, lessons you've learned, scars you've worn with pride.
They might get back to incentives and really just making sure that you follow the money, because healthcare, all the physicians and people, in healthcare know what to do. The question is, there's often a disparity between what they know is the right thing to do and what actually pays the bills. And in order for this to be a sustainable program, it's really important to follow the money, really understand who is holding the bag on the risk. And what's wonderful is this emergence of risk-bearing provider groups, particularly in areas in Medicare and Medicaid, managed Medicaid and Medicare Advantage, where you have value-based primary care groups that are multi-payer. So it's not, it's not just with Humana or United or Aetna, it's with, they're multi-payer. And some of them are at scale and have material scale in some markets. So we have over 150 primary care clinics in the state of Florida under the Conviva and CenterWell brands that are risk-bearing primary care groups. That's a wonderful laboratory. These are clinicians, care teams that are fully at risk for those patients. There's other wonderful organizations out there, ChenMed and Oak Street Health. And I think one lesson learned is to follow the money, understand who is really incented to drive health outcomes and not profit from the adverse outcome, but to profit from preventing the adverse outcome. And I think what's wonderful now is this, it's not just a traditional health plan that has the risk, but for provider groups that are deep in a market, have patient panels that are material, and you can think about partnering with on some of the goals that ARPA-H has identified.
right, great. Andy.
So I'm going to echo some of what was already said. I do think it is about the people in the partnership. And when I think about these types of partnerships on the ground, are these people you want to walk through fire with? Because people are going to throw rocks at it. Things are going to happen that you never expected. And there has to be deep trust there. And so I think it takes work to get to that level of partnership. And I would also argue you sort of know it when you start and you're not there. And if you're not there at the start, you're probably not going to get there. So I think it's really about paying attention to who is in the partnership. It's also about not forgetting critical folks. Yes, it is about the people who are going to receive services. It is also about the frontline folks who are delivering parts of those. I've been involved in projects where we forgot to bring those folks in. And you learn that there's an implementation issue that was dead obvious to them, but the folks higher up didn't really fully understand that. So you really want that service provider perspective. The other piece is around interim data. And we can all get to this place where we're searching for perfect information. We don't need perfect information. What we need are metrics along the way that are telling us that we're getting to where we want to go to. So while we don't care ultimately to be, who said it was like a McDonald's approach, like how many people served actually isn't the bar we're setting out for ourselves. But if we're looking for population level change and we serve very few people, we're not going to get there. So you better be looking at that along the way. And then finally, creating a culture of using that data and not using it in a gotcha way, but instead using it as a tool to improve the project. Quarterly is way too infrequent, particularly during startup. When we're investing in a project in the early days, we're probably on the phone with you weekly. And we're looking at all of those early metrics because that's very much how we see ourselves as not just an investor that's cutting a check and walking away, but actually we stand to lose. So we want to know if you're hitting those metrics, and if you hit bumps in the road, we're going to try and help solve that problem. So I think those are some of the key things that I would focus on.
Will.
So Kavita asked that question, and I thought I had two really good answers. But I'm going to just extend a tiny bit, but they were fully taken, frankly. I think
just answer the question you wanted to answer. Just do.
Oh, this is good though. I think the interim, so none of the solutions are going to be like flip a switch and we can solve this outcome. Every single one is going to require evolution, learning on the ground, figuring it out. It's tragic to do an analysis at 6 months or a year and say, oh, it's not working. This is a bad idea. We got to get rid of this idea. The rapid cycle nature of assessment is at the core of our ability. Any of these to be successful needs some sort of rapid cycle evaluation. And I think it's not about making a decision, yes or no. It's not a binary decision, yes or no. Are we going to continue doing this? It's really about learning and having a continuous learning cycle. I think at CMMI, we have the best examples of waiting too long to evaluate and then having these binary results that make everything that's attempted look like a failure, regardless of the remarkable amounts of learning that are happening on the ground in those models. That's something that absolutely can't be a feature of this, or in particular where there's got to be so much sort of partnership and nimbleness in a market to figure out how to be successful. The other thing, and this is maybe a little bit, I'll sound a little jaded. I think you have to be really careful in terms of how you pick the outcome. The best intentions around a great outcome can be sort of overtaken by an opportunity to game the result. And everyone's intentions here are good, without question. And without question, folks who participate are participating because they want to impact and improve public health and want to improve the outcomes they're focused on. But everyone's running a business essentially. And day in, day out, they got to make sure their business is successful, making sure that those outcomes are really capturing what you want to model in society. And that it's not gameable. It's not, there aren't ways to sort of, around the edge look like you're successful, but not really solve the problem, is absolutely critical, setting it up front.
No, you're not too jaded. All right. So we've got, this is the time where we'll do questions. We have roving mics, and then I know we have online. So I'm going to let someone smarter than me tell me when there's something.
Hey, thanks so much. I'm Lonnie Sciota from Arizona State University. I've really been tracking this conversation about outcomes, right? Because it's so crucial. And we've already discussed the difference between proximal and distal outcomes. The thing is, in this space, take time, when you're talking about substance use disorder and opioid overdose. They're big, they're extremely important, and it takes time to get there before you're going to start to see those results. The proximal outcomes and indicators sometimes have a way of going up before they go down. So I've had conversations with some of my colleagues around the outcome that's been stated for opioid use disorder. Let's take ED visits, right? Frequently, when someone overdoses, they refuse transport. But we actually don't want them to do that. We want them to go to the emergency room. If we're doing our job, if we're having impact, they do go to the ED. They do have an opportunity that firefighters and police officers and EMTs can't necessarily provide in the field, for a longer assessment, for a potential for a longer term intervention, for at least discussion of, if not prescription of medication assisted treatment, right? MOUD. And so that doesn't happen if you don't have that contact with the ED. We want people to go to the ED, but if what you're measuring is a reduction in ED visits, that's problematic, right? We can talk about calls, right? 911 calls. The problem is hardly anyone calls 911 and says, I've got someone here who had an opioid overdose. What they do is they call and say, I have someone who's unconscious, unresponsive. I can't wake them up. And so it's incredibly complicated space. I'm interested in funders, how you deal with the possibility of outcome metrics that have a tendency to be curvilinear, right? Where there's that risk that they might go up before going down.
So I'll speak to that from some of our practical experience. I think what we try and do is work with the partners in the project and leverage their expertise, because that's not going to be immediately obvious to me. And we've done other projects where we understand that a great example is supportive housing, right? Which is well-worn path in terms of much better health outcomes. And when you really talk about the social determinants of health, it's really an important intervention. Well, sometimes medical costs go up because somebody's connected to the medical system for the first time. And so again, that is part of this collaborative process. And the idea of, what I think is exciting about this is it's eyes on the prize of where we want to get to. I think the work that we would suggest for partnerships looking to lead this is doing this very hard work to say, okay, along the way, what are the things that I can be looking at with my partners, with my investors, to know we're getting there based on what we know from the field? And that's why you have to have those right people there.
Just to add that, healthcare is so full of things, like you mentioned, where there's transitory effects and there's a long-term run rate. And so as you whoever is designing a program in an area, just make sure you think through those transitory effects, because you're right. I can't comment on that specific example, but there are other experts who can, and that's really where the project leaders and the program leaders need to think through what are those transitory effects. We may see an increase in utilization. I will say in areas that I'm very close to, say, Medicare Advantage, we usually see a significant increase in costs in the initial year as we put in our clinical programs. And so I would say most health plans and risk-bearing entities will understand that difference between transitory and long-term. And there's a J-curve effect that we often talk about. And so make sure as you design your programs, you've thought through that, and at least from the investor side, that should be familiar.
And most of us, I would say all four of us, our average investment hold time is a long time. It's at least our firm, it's about 7 to 10 years. And that tends to be a little bit longer than most people talk about in venture. And we've had a lot of investments. If you take out biotech, a lot of kind of health services investments that are like going on 12 to 15 years. So you want a partner that's in it for the long haul for that reason, because you can smooth out the bumps that way. So it's worth talking very honestly, like, when do you expect it? There might be what ARPA-H sets out, but if you're with a partner that's in it for the long haul, which is the right partner, then they're not looking for the short-term wins, because we know that this is rocky and complicated, and you want to give the team that knows what they're doing, the A team, the length, kind of distance. All right, I know we had a bunch of hands. I'm going to try to make sure. Okay. Oh, sorry. You're doing the, okay.
Hi.
Let's try to make it. I'm not trying to put pressure on you. You seem very sweet, but like, let's keep it short so I can make sure we get to everyone. I wasn't sure how popular we would be before lunch, but
Very popular.
popular. Yes.
Hi,
Okay.
Reza Alavi, Quintuple Aim Solutions. How do you think about the size of the incentive dollars compared to the size of the healthcare cost? Right, so $60 million sounds like a lot, but for a 700,000 population for cardiovascular, we're talking $3-4 billion of healthcare spend. So impacting all the stakeholders' activities to get cholesterol and blood pressure and real change at a population health level, that's less than 1% of the dollars of activity. Does that get real change and or investment or movement?
I'll give it a shot.
Okay, Will.
I think the one, so the one thing to recognize, so no one believes that this is going to be the investment that's going to solve the problem nationally. We're trying to sort of test and learn our way to an approach, a set of tactics, a set of strategies that allow us to learn our way to get there. It's true, it's a massive, overall burden of cost in the US, but locally in a market, the folks that need to participate are generally community-based organizations or they're venture-backed startups. These are like small organizations that this amount of money is enough to motivate them. Most importantly, this amount of money is enough to give them breathing room, to give them sort of space to innovate, space to figure out their clinical model, space to test and learn their way around how to create new partnerships, space to hire up the right team, which can be very small and very local. But you do it and you do it right. Our job as investors, our job as public health officials is to identify those kernels of awesomeness and figure out how to disseminate them. And that's the job. That's what Heroes does. It's like, how do you use these experiments to identify those kernels of absolute awesomeness? And then you got a lot of people here on chairs showing you their socks who are
So look at your socks.
yeah, I got good socks today. I stepped up my sock game today. I didn't realize I was going to be rewarded for that. This is what we look for. We're looking for the opportunity. Holy smokes! Now you can hear me.
Yeah, it's amazing. The mic works.
Wow. Yes, this is it. This is like you learn locally, and there's a lot of folks here ready to scale it.
All right.
The sustainability should though come from outcomes that take waste out of the system, and other organizations will then lean into scaling it up.
All right, we have
Hi.
here.
Thank you so much. My name is Roshini Naidu. I'm from Arizona State University and a fellow at Harvard University. I have a question to gauge your thoughts on the involvement of the patient in the incentives. In non-healthcare environments, in traditional retail markets, it's essentially the consumer that determines the value of a service through pricing. It becomes quite complicated when we talk about healthcare, but essentially the end user is the patient, is the consumer. So, what are your thoughts around incentives, especially for the sustainability in this marketplace that we're all envisioning today? Thank you.
Maybe I'll start. So I mentioned engagement being the first thing that we look at. It's what I meant was patient engagement or customer engagement. And what we're really trying to see is some interaction with the intervention, because if you don't have an uplift on that, nothing else downstream will work. And so I think as you all think about metrics, the initial metric, well before any health needle of an outcome moves, is our customers, patients engaging with the solution. And I mean, as you think about then the use of the resources, in many health plans, there are incentives for doing healthy behaviors, or if you get your mammogram or colonoscopy, or taking additional steps in the day, they can be incentives that are built around that could nudge or improve engagement. But I'm glad you brought it up, because that's absolutely, usually it's the first gate that we as investors often look at. Are we seeing engagement with the idea?
Okay, one other just quick thing to note is that there's a whole host of compliance issues around rewarding patients that frankly I think are kind of challenging and kind of get in the way sometimes. There's a lot of, so in Medicare in particular, there's a whole host of limits to how you can reward patients for behaviors, and because of perceptions of coercion or kickbacks. But in a lot of ways, we're losing the most important lever, the lever of a human, and they're aligning their financial incentives with their health outcome incentives. So I think you're raising a really important point, and one that probably, I don't know, it's interesting to think if in the setting of an ARPA experiment, some things could be waived, and there are some opportunities to be more flexible around how to engage the patient in their own health.
Well, if I could just, I do think though, it doesn't take a lot to incent behavior change. It could be an extra $5 for doing, taking, getting your blood test done, or whatever it may be. And it's often smaller economics or point systems that can drive more engagement. But you're absolutely right. There's parameters around it, but you often don't need to, provide a lot of incentive to see greater engagement.
Yeah, I agree.
Yeah, I was just going to add, in real life, we've actually looked at a model that incorporated some relatively modest patient incentives that are really built around sort of best thinking and behavioral economics. So
remember, time is the most valuable commodity. So often it's finding even access points when they can get care. For pregnant women who are working 2 jobs, we'll be able to kind of meet you at the grocery store on a Friday night, because that's when people are shopping and getting things together for their household. So often the incentives can be in the form of convenience, and that's very different. I think this is the last question. No? Okay, one more. All right.
Hi, I'm Paul Meyer, Smart Health Network, formerly Text for Baby Daddy. Question is structural, and your advice to ARPA-H. We had this sort of challenge earlier to really think structurally. So I grew up in public health. Public health care, about everybody had no money. And meanwhile, our country is spending $4 or $5 trillion billing for doctor visits, like traditionally. Right. So we've been on this sort of 15-year experiment with, value-based care, quote unquote, population health. But in some ways, I think about that as sort of like public health mediated, delivered through our fragmented payer provider mix. As we think about then sort of some of these interventions and traditional structural models, venture investment, whatever, who ultimately are then trying to sell services and eventually exit to those existing enterprises, what opportunity do you have and advice for ARPA-H taking big, bold bets to actually break out of that structural trap that ultimately we're basically beholden to the enterprises that are basically consuming 18% and growing of our GDP to actually do what public health has been doing for centuries. But, and so I just think as I listen to this, there's such an opportunity just not to go through the same patterns. And if we don't, for me, that is the core structural problem, that we basically have, we still haven't resolved the fundamental tension between the Hippocratic Oath and fiduciary duty to maximize returns. It feels like it would be a waste with this big, bold bet that ARPA-H is taking not to confront some of that fundamental structural issue in the way our society is structured.
So can I jump in for a second? So I do think at the same time that this conversation is happening in the health space, there's an investment conversation going on around impact investment. And I think on a structural level, right, one of the friction points is if ultimately what we are doing is looking at venture investments, it is what is the exit? And the exit has to be big and big multiples. I think from where we sit, one of the reasons early on we focused on debt is because it doesn't require a 10x exit. And my deeply held belief is that particularly these types of projects are not going to provide that return profile. And so what we look at is how is this both aligned and driving better outcomes and public health impacts, which is what our investors have bought into. Now, that doesn't mean we're going to do it at 1%, right? We have commercial capital and we are looking for returns. And we spend a lot of time thinking about risk mitigation. But I do think there are other tools out there. And that's not to say that I don't think that venture-backed companies don't have a huge role to play in efforts like this one. It's just, I think for this particular opportunity, it is more aligned with debt. And what I see as the opportunity for venture-backed companies is to demonstrate and grow with some working capital that is not pushing an exit, but is really looking for sort of more near-term outcomes. I don't know if that gets at what you're saying and some of the tension, but that's part of how sort of sitting in a seat of an impact investor, that's how we're increasingly thinking about the work.
All right, but there was, okay.
Hi, this is.
You're in between us and lunch, no problem.
Sorry. Pretty short. Yeah, thank you.
Let's keep it.
So Vikram, I'm from Stanford. I have a question to build on that, which is structural and on technology. Our HEROES program is ambitious, bold moonshot in comparison to VVC, right? VVC was mainly supported by payer data, 45 to 60 days turnover time. But some of the things here we're talking about very fast, right? Missing 26 weeks of ultrasound, you have to act like within 2 weeks. How that structural technological problem is going to get resolved? I'm curious to hear that thought.
I don't know if I agree with the premise of your point, though. I think in value-based care, you have real-time access to hospitals and admissions and discharges and transfers, and then it helps the risk-bearing provider be fully aware of what their patient is doing effectively in real time. And the better systems, whether it's companies like Humana or United, and they've built models like that. And so I think the broader question of real-time data access is an important one. And I do think that's where collaboration with organizations that are in VBC type models, in part because they've had to build that real-time information exchange in order for their risk-bearing provider partners to be successful, can be a good avenue to get more information more upstream versus waiting for the claim.
Yeah, I'll just pile on real fast. I think directly as a result of the efforts around value-based care adoption, we've seen incredible investment in technology for that very reason. Hey, maybe it's not perfect. Maybe we don't have the data flows don't work optimally. But that was definitely a step in that direction of creating an incentive structure for providers to do the right thing and reward them for quality, reward them for health outcomes, reward them for efficiency. And they leveraging data better to be able to manage populations better has been a core principle in essentially everybody that's trying to deliver value-based care well. So I'll stand with Vishal on that one.
All right. Well, join me in thanking our panel. Lunchtime, Darshak, you've got some announcements.
Thank you so much. What I'll just say is I'm so grateful to this panel. Just on a personal level, I really appreciate the efforts many of you made to be here. I know that wasn't easy. So greatly appreciated. We're going to go ahead and get started. So thank you all for all your attention and time this morning. what we're going to do is we're going to go ahead and get started with our next panel. And what I'll do is I'm going to defer to my colleague, Claire Darshak, to introduce herself and the rest of the panelists, and we'll go from here. Thank you.
Good afternoon. So we have a panel today I'm really excited about, and we have two remote speakers. So thank you both for being online. My name is Claire Jericho, and I help support the HEROES program rollout. My background is an infectious disease and behavioral epidemiologist, and I've worked on the ground in public health for quite some time. And when I got the opportunity to help operationalize this and make this happen, I jumped at the chance. So I'm really looking forward to talking to all of our panelists today. It is around outcome buying, and we have philanthropy and employers. And I'm going to ask them just to introduce themselves one by one, talk a little bit about their background and their organization, and then we can have a nice discussion. So let's start with online, maybe Elizabeth Mitchell, would you like to begin?
Certainly. Hi there. Sorry, I'm not in person. My name is Elizabeth Mitchell. I run the Purchase Business on Health. We're a 501c3, but we are a membership organization of jumbo employers like Walmart, Apple, Boeing, Microsoft, and public purchasers like CalPERS, Washington Healthcare Authority, and big states who are purchasing healthcare on behalf of over 25 million Americans. So they are very invested in the healthcare system.
Thanks so much. Dave, would you like to go?
Sure. Hello, everybody. Also, sorry for being here virtually and not in person. My name is Dave Reagan. I am the president of a healthcare workers union called United Healthcare Workers West. We're part of the Service Employees International Union. We represent about 115,000 healthcare workers in California and in Arizona. And our organization, we at least attempt to not just be a traditional labor union, but also to do some experimentation, both in the policy and the philanthropic space. And in the past few years, we've been involved in efforts to expand Medicaid through citizen-initiated ballot efforts in 7 different states. We've also done some experimentation, oftentimes with healthcare employers and state officials around creating workforce solutions. And then the third thing, which I think is the subject of today's conversation, is around, what can we do using all the tools at our disposal to improve healthcare outcomes, particularly at a scale that matters. So nice to be here.
Thank you, Dave. All right, Mark, do you have a microphone?
I do. Okay, so I'm Mark Miller. I guess the first question is about myself. I started off at the Urban Institute as a research person. I've worked at the Office of Management and Budget, the Congressional Budget Office. I ran the Medicare Payment Advisory Commission for 15 years. And then about five and a half years ago, I went to Arnold Ventures. Arnold Ventures is a philanthropy. The couple that started it are the kind of giving pledge, to spend out their wealth while they're alive. The Arnold Ventures does a range of social policy issues, criminal justice, contraception, studying gun violence, infrastructure, public finance, education. I'm pretty sure I'm going to forget something, and then healthcare. And I do the healthcare portfolio. Generally, the way the organization works is to fund research, build an evidence base, develop. A lot of our work is policy focused, whether at the federal or state level, changing law, regulation at the federal and state level, but we also have market disruption types of situations. We worked with some hospitals to fund the development of low cost but often supply constrained generic drugs, things like that. But anyway, develop evidence, policy, or market disruption, try and educate, change people's minds, that type of thing. Is that
Wonderful.
what you're looking for?
Okay. Last but not least.
Great, thank you. Maybe just a little bit about myself. Shao Chi Sim, I'm the Executive VP for Health Policy Research and Strategic Partnerships at Episcopal Health Foundation. We are based in Houston, Texas. So I spent, I would say, most of my adult life in New York City. Prior to relocating to Texas, I was working for large federally qualified health centers in New York City. Some of my thought processes, what I'm going to be about to say, it's driven from my work in the Northeast. However, over the past 9 years, really got a great opportunity to do a lot of hands-on policy work, research work in the great state of Texas, where things can happen. In terms of the foundation, Episcopal Health Foundations, we are part of the Episcopal Diocese of Texas. Basically, what happened was the diocese used to own a hospital system. They're no longer interested in running a hospital system. They sold it and created the foundations. We do much of our grant making, research, policy work, engagement work, especially with our congregations and community groups throughout 80 counties in Southeast Texas, covering most urban areas like Houston, Austin, as well as the Fort Worth area and many of the non-urban areas. One thing that kind of has been our foundation tagline for the last 9+ years is that what we wanted to do is really to advance kind of like this whole notion of health, not just healthcare. Really trying to broaden the conversation, the policy conversation in Texas about looking at health in a holistic way, looking at health in a much more preventative fashion. And that's why we got so excited and intrigued, when we found out about Darshak's presentation on ARPA-H, on the HEROES program. And we have done quite a bit in terms of working with stakeholders across the spectrum in Texas, both with state Medicaid agencies, Health and Human Services, the 17 Medicaid managed care organizations, as well as many of the safety net clinics, FQs, rural hospitals, rural clinics. So we are super excited to be part of these conversations, and I will be happy to share some of our earlier work in terms of advancing our social determinants of health or non-medical driver of health agenda in Texas. Thank you.
Thank you all. So we have quite kind of a diverse panel of philanthropy and employers, and kind of all with different strategic initiatives. But I think you've all been investing in different ways in health, and either outcome-based or population health and prevention. So what I think would be great, because I don't think everyone's intimately familiar with all of your organizations, is if you each maybe give one example of a program or outcome-based financing or a health program, population health program you've invested in that you're really proud of, and tell us a little bit about that. And I'll start with you, Elizabeth.
Great, thank you. I have a lot to choose from, but one thing that I want to be really clear is that jumbo employers thought that they were buying outcomes, right? And our members spend, billions and billions of dollars a year on healthcare. And a CFO recently came to one of our member reps and said, so for the billions of dollars we're spending, are our employees and families' health improving? And unfortunately, the answer is no. And so they're digging into that, right? Just this is one example, but all of them are, because they have unfortunately been doing all of their buying through health plans. And it turns out that those incentives are not at all aligned. And the fee-for-service legacy systems don't enable payment innovation, which is what most partners need. And then the lack of transparency and accountability has made it really difficult. So many of my members, as recently as yesterday, are looking to go direct. And we have actually released an RFP for advanced primary care, identifying partners who will meet employer standards and goals for better health outcomes, better access, better equity, better total cost. And we are finding that there are partners out there, but you have to take sort of an innovative approach to finding them. It is not the traditional sort of go out to bid and a health plan responds. And we are realizing it has to be regional because you've got to concentrate enough headcount to make it possible. So we have now done this in 3 markets for 2024, and the response is fantastic because people want to practice differently. So happy to share more about that. But another one that I'm just really proud of is in California, where we've run sort of a regional health improvement collaborative with all the stakeholders who come together. And we did this actually with CMS a few years ago. And we were able to quantify that even in small and rural practices where you enable them with data and partnerships and technical assistance, we were able to avoid over 50,000 unnecessary emergency room visits. We were able to quantifiably improve health outcomes. And if you can do this sort of in one region with a small nonprofit, I know it's scalable. So we are really encouraged about this new approach.
Wonderful. Thank you. Dave?
Sure. I realize that the example that I want to talk about is not sort of a classic philanthropic investment thing, but it's a mechanism that we believe is really important and often overlooked and underutilized. And obviously, as a workers' organization, as a labor union, we represent people who are delivering care every single day. And one of the things that I do think is interesting, and we struggle to get our employers to do this. And I think there are opportunities working with state government, working with the federal government, working with philanthropies to encourage and incentivize, through the mechanism of collective bargaining where it does exist. Because as Elizabeth said, how do you get enough headcount that you can concentrate these things? If you can't scale it to some level that's meaningful, you can't get there. And so I just want to share with people that, we represent 60,000 people who work at Kaiser Permanente in California. I'm interested in Shay's comment as somebody who spent some time in the FQHC world, because we've now embarked on a discussion at both the policy and the workforce level with, through the trade association in California with called the Primary Care Association out here. But we reached an agreement last fall with Kaiser, where we tie a piece of compensation for unionized employees to measurable healthcare outcomes. Particularly, are we lowering the blood pressure of the 9 million people who Kaiser takes care of in California, where this is tracked and measured through the course of the year? If we succeed in reducing the aggregate tracking of blood pressure for that population, workers get a bonus, based on an annual, there's a formula that goes for this, and we do that annually. Similarly, we also agreed to do the same thing for flu vaccination levels for the population as a whole. And we take seriously the job that, part of the day-to-day work is, are we hitting the numbers? Are we improving the healthcare of a group of people that we take care of? And, and I can say, Kaiser is the largest employer that we deal with, but it's frankly a struggle. I think in Elizabeth's world, right, people get it from a payer perspective. Typically, people don't get it from a workforce perspective. And so I just want to share with everyone, there are opportunities out there to engage the workforce. It doesn't have to be through collective bargaining, but that's a mechanism that actually, lends itself to these sorts of things, and tying some piece of some piece of at-risk compensation to quantifiable healthcare outcomes is something we're comfortable with. We have a history of doing it, and we just changed the things we're going to measure for the next 4 years as a result of a set of national negotiations.
What I really like about what you both just said was, trying things at a smaller level, at a regional level, and seeing what's working and what's not, and then working to scale that. And I think you both spoke to kind of being able to look at that, the evidence base, seeing that the outcomes were happening, and then thinking through how best to scale it. And the regional approach, which is within Heroes, what we are taking to, and really. There's so many different mechanisms and tools that you do have, and that you on the ground know better than we may. And so having that flexibility in Heroes is really what we are striving to create and support. So thank you, both of you. Mark, do you want to give us one example from your program?
It won't be one example. So
Or two.
No, I don't want to do that.
Okay.
So,
What do you want to do?
all right, here's what I want to do. I am going to answer your question. I'll give you a few examples, but I'm going to have to walk you in just so that people kind of know where we're coming from. So the healthcare portfolio's primary objective is to reduce cost. And cost, in our mind, is for, on the commercial side, the employer and the employee who's paying for insurance on that side, and on the public side, taxpayer, and if you're a Medicare beneficiary, your premiums and those types of things. I want to reinforce that point before I answer your question directly, because I also think cost is an outcome. I mean, we want to avoid hospitalizations, emergency rooms, blood pressure, those types of things, but we also want things to be affordable because people won't seek the care if they can't afford it. And there's some other reasons, but at least that one. So I just would like that in your mind. So I have parts of my portfolio that are very much directed at the prices of things, which I will not get into, and instead talk about utilization. And utilization, very much, we drive at things at the population level. And a couple of areas that we're focused on and looking, and the way our interest in this would work as follows, is to the extent that there is something in managing a person's health that actually is effective, we would like that evidence, to study it and be clear that it is effective. And then if we could integrate it through either policy on the public side or through, market incentives on the commercial side, that's how we would come at things. And at least three areas, and these are now my answers to your questions. I'm sorry to take you around the block, but I did want to make a point. There's a couple of things. One, there's 12 million dually eligibles in this country who have Medicare and Medicaid eligibility. They are very complex, very sick people. We are trying to produce an integrated Medicare and Medicaid benefit and delivery system for them. We're working on legislation at the federal level. We're also providing technical assistance at the state level. If there was evidence, for example, that ways to deal with cardiovascular that should be integrated into those delivery systems, one of the ARPA objectives, we would want to integrate that. We are also looking at different ways of delivering primary care, and then, of course, things like total cost of care, like accountable care organizations. And that's how I think it kind of intersects with what ARPA is up to here. Thank you for letting me go around the block.
Of course.
Sure. I guess I'll just share my perspective from a couple of different ways. As I mentioned before, the work of our foundation is really about changing the conversation or the policy conversations among stakeholders in the state, moving from a healthcare focus to a health focus. And in that regard, we have done a lot of work from commissioning polling to, being very intentional to engage various payers group, health system payers group, as well as safety net providers. One thing that really struck me about the HEROES program is the opportunity to foster and create this sort of cross-sectorial partnerships. And the foundation has done quite a bit in terms of supporting various cross-sectorial alliances, partnerships, coalitions, whatever you want to call it, where there's always an an unequal dynamics between the payers and the providers, the community organizations and the health systems. I think it's really, this is something that's really germane to the conversation about, the model as we advance the work, right? As much as we wanted to place a heavy emphasis on healthcare sector, I think there's a huge role, for the community partners. So I'll mention that. The other type of work the foundations have done over the years was that we started with a co-funded partnership with RWJF, but later on we decided to fund the initiative along. We've been really serving as a neutral forum to engage all the different type of Medicaid health plans in the states so that they are able to share best practices, learn from mistakes, and really forge some type of conversation on social determinants of health. Much of that work actually, led to the release from Texas Medicaid, their first time ever, their non-medical driver of health action plans, where they're placing more focus on food, transportation, and housing among Medicaid beneficiaries, as well as for the first time ever in the Texas state legislature, we were able to get Republican leadership support for a community health worker / doula bill that actually expand the Medicaid provider type so that they're going to be able to be reimbursed to perform case management under pregnant children and pregnant women's program with Texas Medicaid. This is a very, very kind of incremental step. I'm not kind of wanted to declare victory today, but I think it's a very small step in terms of opening up the door. Again, think about the equity dynamics, think about, that there's a lot of non-healthcare workforce issues, could be addressed, through the HEROES program. So I just want to offer those as some food for thoughts.
Thank you. So Xiaoxi, do you, given your work really kind of on the ground, you do a lot of kind of policy work up here and convening work, as well as you're really integrated into the FQHCs and the service delivery mechanisms. What would you say, in thinking through the HEROES program, what you're most excited about, which health outcome or health outcomes, and really how you envision yourself engaging with other organizations?
Sure. Yeah, it's kind of very refreshing when I first was reviewing the information on your guys' website and Darshak's slide deck. I think what this model allows us to do is that this is really, at the end of the day, at its core, this model is a true community health prevention model. It really kind of take away or peel off the whole labeling or identity about we only care about folks with commercial health insurance. We only care about folks with Medicaid coverage or Medicare coverage. This is every single resident, in the designated area. And for a state as large as Texas, as having its own challenges, with many of the, uninsured residents, I see this as so exciting, so in line, with the whole community health prevention framework. I also see this as an opportunity to engage non-traditional type of partners and organizations in this work. It's all about kind of like, the old saying of, we are all in this together. And it's not just about one health system or one health plans or one health foundations. And we will see, and the foundation is very interested. If some of you wanted to come up and talk to me later on about, your potential interest in the Texas area, I've gotten a number of initial interest expressed by multiple partners within different part of Texas.
So it sounds like convener, health accelerator, outcome buyer, investor. You could play multiple roles potentially.
Yeah, definitely. We are interested in furthering the conversation.
Wonderful. Elizabeth, I will go to you. Maybe talk a little bit about if you've, in reading HEROES, if you have specific health outcomes that you are particularly excited about as an organization playing a role and moving forward, and kind of where you would see your role.
Sure. All of them are important. And I did let Darshak know we had hoped mental health would also be there, but understand the measurement challenges. But our members are focused on all of these areas. And I think that's actually an important point for this. Jumbo employers, at least the ones that I work with, are as committed to improving equity and access and community health outcomes as anyone. So there aren't always the tables to sort of have those cross-sector conversations, but they are very committed to improvement on all of those fronts. Something that we have been really focused on for the last 2 years is maternal health outcomes. As you know, there's an absolute crisis in this country. Equity outcomes, it's really dismal. And so led by Walmart and Qualcomm, we have been leading an initiative across our membership to actually drive improvement there. Everything from literally paying for doulas in the community to changing benefits, and really trying to even address workforce shortages in some areas. So our members are very committed to this. They came up with common measures to share with all of their partners so that we're trying to sort of reduce the noise of competing incentives. But jumbo employers can't do it alone. Obviously, you've got to have the community partners, the clinicians, the hospitals or birth centers. And so we are now moving into a phase of implementation. And this is something that could really enable that. So we're particularly focused on maternal health outcomes and equity, but committed to all of the areas of improvement.
That's exciting. Dave, do you have any specific health outcomes in the HEROES program that you are excited about in working in currently or excited to pursue?
Yeah, I think of the four that are discussed in the materials, 3 of them certainly are top tier issues in our world, and that's maternal health outcomes, the heart attack and stroke area, and alcohol related issues. The answer is yes. I do think, and Elizabeth just touched on it, at the same time that everybody's interested in what can we accomplish, can we measure it, can we deliver it, I don't have to tell this group that healthcare is an incredibly complicated environment to operate in. And the simple reality is there is a crisis level workforce shortage across the country. We do not have the workforce to deliver the care that is needed. And I think this is a particular problem, for the care for poor people and the care that's delivered by practitioners or healthcare workers who are at the lower end of, the income ladder in the industry. Here in California, we have 14 million Medi-Cal beneficiaries, and you can't hire certified nursing assistants, you can't hire doulas, you can't hire community health workers. And we lack a workforce strategy to create these. And it is mystifying to me that for an industry that represents a little over 20% of gross domestic product, we don't have a state level workforce strategy. There is no vocational focused initiative. And I just want to share with folks that we created a healthcare training operation about 5 years ago. We call it Futuro Health. And the idea was simple, that since we represent healthcare workers and lots of people in this industry, not all kids decide to go to a traditional 4-year, college type situation. And there's lots of people out there, healthcare jobs still, are by and large considered to be reasonable career options. And so, we've recruited people to become medical assistants, phlebotomists, surge techs. We're starting to expand our portfolio. The problem we have is there's a woeful inadequacy of how do you connect, emerging healthcare workers with willing employers. And it's really been shocking that we don't have the mechanisms through state government and through the employer community to connect these dots. And I do think, when you look at the space for innovation and philanthropy, you can look at a county, you can look at a metropolitan area, and we know how many CNAs are we short? How many behavioral health care workers are we short? How many doulas do we need? And what we've discovered through, we've trained 10,000 people in the last 5 years, and the hardest part is connecting them to jobs. And we've done this where it's a tuition-free program. I won't go into all of that. But I think something, if you look at the low-hanging fruit, where do you get the best return on investment, but where you don't have the workforce, particularly lower down? And if people who want to be healthcare workers knew that if I go through a program and I'm not going to end up in debt to do it, there's a job on the other side, and where employers signed up that if you create 50 doulas in the San Diego metropolitan area, we will hire them. And they know that at the front end, those people exist. And so the one thing I want to say to this group is, if we can't solve the healthcare outcome problem if we lack the workforce, and it is a crisis level to do it. And this is not rocket science. This is about add water and stir. It takes focus, and I'm excited about possibilities that exist in that area.
Yeah, I think you make a really good point, is that you're very much in a unique position where your constituents, over 100,000, you're both kind of the outcome buyer or purchaser of some of these population health outcomes, but your constituents are actually the people who provide the services. And, can you speak a little about how that has influenced your what you invest in and how you think about your investment strategy?
Is that for me, Claire?
Yeah, sorry, Dave.
No, sure. And I'll be upfront about it. We've used the mechanism of collective bargaining to create a not-for-profit 501c3 operation called Futuro Health. We negotiated over 5 years contributions of $240 million, where we want to train tens of thousands of healthcare workers, where the money is used to pay the tuition. Because for so many people at that level of the income ladder, if you go to some kind of an online or some kind of a for-profit training program, you can easily end up with debt of $20,000 to $30,000, and you don't get a job on the other side. That is a very, very frequent occurrence. And so I think what we've demonstrated in the last 4 years is you can create, using technology, you can create high quality training programs for needed healthcare positions. What we have not yet really solved to our satisfaction is how do we connect those people? And so again, I think what we all know, and the information exists in a given community, what do we lack to treat the folks, whether it's maternal health, whether it's, basic heart attack and stroke type stuff, where you need community healthcare workers, doulas, that kind of thing. It's a very concrete, solvable problem. And I do think the resources exist. And what employers, what I think they need to know is, where is the convening mechanism? It could be philanthropy. I wish it was more often state government, to say, if we create these, there are purchasers of the workforce to deliver the needed things. And I think that's where we're at in the evolution of what we're working on in that space.
So Dave, this might be a real-time pilot launch, but I've got employers asking me all the time, how do they invest in the workforce and support growth? So we should definitely follow up.
Yeah, no, it's a classic last mile problem that we've discovered. And I think the world is just so noisy, Elizabeth, that we kind of don't find it, but I'd love to follow up with you. So thank you for that.
Wonderful. Well, look, the magic's happening already. We love it. And so, Mark, I'll end with you before we go to Q&A. Is there I guess my question to you is in this space where you are clearly interested in cost and equity, is there one of the health outcomes or multiple that really interests you? And what's your kind of philanthropy vision, and who, what could people do to maybe like partner with you, or what are you looking for in Health Accelerator partners?
Yeah, so given the populations in question, certainly cardiovascular, the alcoholism, and the maternal are all relevant to the work that we're trying to do. And like I said, it is cost focused, but in a sense, what we're trying to do is either improve quality without adding a ton of cost, or keeping quality neutral and reducing costs. And the way we would think about these things, again, I gave you some population-based delivery system examples: primary care, the Medicare and Medicaid population, then there's kind of total cost of care in Medicare. And the way we would approach this is, if there's funding that's needed to show that this intervention actually works, because we would want objective, separate evidence, that this actually works, and also work that suggests or shows that it actually can be scalable, as opposed to very peculiar to the circumstances where it occurred. And then, like I said, if it has those kinds of effects, it works, and you could actually push it out in a way that people could use, then we would either be trying to drive it through policy or drive it through some kind of market intervention, and we can support those kinds of activities.
Wonderful. Yes, go for it.
Yeah, I just want to make one additional point about maternal health. Again, I'm going to talk from kind of the perspective of from Texas. CMS, I think just about a month ago, approved Texas Medicaid state plan amendment to basically extend Medicaid postpartum coverage from 2 months to 12 months. There's actually tremendous opportunity right now, and I've been having conversations in the state with both safety net providers, health systems folks, as well as the MCOs. Now they literally have 20 months instead of before, where they have much less than 20 months to support, to find ways to work with the Medicaid members, from first trimester onward to 12 months after the delivery. There's tremendous potential and opportunities as we think about the type of, whether you're talking about mortality, health disease burden, so on and so forth. And I think our foundation will be very, very interested to figure out, what type of interventions, how should we collaborate, how do we kind of get into a full alignment across various actors in the system.
Wonderful, thank you. Thanks to everyone on the panel. We're going to do about 15 minutes of Q&A now. And so, Mark, if anyone has questions, Mark has a microphone, or I do.
Okay, good talk.
Post-lunch slump.
Yeah. This is really great to see. I'm Dave Callion. I'm with a group called Fourth Sector. We're a service-disabled veteran-owned small business that helps the Veterans Health Administration and the military health system to build a lot of the data infrastructure and ecosystem that you need to do continuous improvement, and ideally get to the kind of healthcare orchestration that we all know we need across seams in our health system. I really struggle with seeing how you do this at scale in the community where you don't have the data infrastructure, where you don't have the ability to kind of observe outcomes and attribute change in a way that you can build controlled time series trials, do A/B tests, assess whether something is actually making the impact that you think it is, and then being able to double down on those things that are, especially in the time frame that we're doing it in the 3 years that we've got. It's going to take a significant investment from anybody coming in as a accelerator to build that infrastructure that they're going to have to go at risk for. We heard a few different models that are debt financed or other approaches to seed this. And I think that I'm not seeing that in this program. I'm wondering how you're thinking about that from a health outcomes buyer's perspective, if you're going to really get to achieve the goals that you see with the structure of the program as it stands.
Is that for anyone in specific, or is it for the ARPA-H team?
It's for the buyers, really.
Okay.
I mean, the folks who are buying the outcomes have to think about this.
Anyone have a
don't know why you're looking at me. I was the one that didn't answer your question right. But, one of the things I would say, can you feel the tension between us? It's okay. What I would say is we have at least, and it depends very much on the circumstance. So I don't want anybody to walk out of the room and thinking this is a blank statement that this guy said he would fund your thing, just to be clear. All right. Well, isn't that what's going on here? We do, in fact, fund straight data, like resource types of things. Now, in a circumstance like this, if I'm following the ball here, which I'm not always 100% sure I am, and any day in any setting, but the notion of, like doing a study and assembling enough data to show that something works, but then also this point I was making about how you implement it, and some of that might involve, well, if we're going to support this, we have to build out a data set. So we do make investments that are purely just, this is a public resource of data that can be used. Even though I didn't say it, we do recognize that as important, but it's very specific to the thing as opposed to just, oh, we just do that, for fun and that kind of thing. Sorry.
Yeah, based on my limited understanding, my sense is, the data burden will be mostly kind of like, in terms of addressing the burden issue, ARPA-H staff, will be sharing, a very sophisticated data reporting infrastructure, your mapping, website, and I'm not the best person to talk about it. I'm sure Clay and your colleagues, can definitely speak to that. But the larger point that I think you were raising, it's really kind of highlighting, how insufficient and how data always become a constant barrier whenever we're trying to convene groups across sectors, whenever we're trying to really hone in on outcomes, on trying to figure out whether we move the needle. And I completely agree. This is a sector that is underinvested. This is a sector that has not been, no one paid full attention to it.
Anyone online?
I would just say that there are some data assets out there. I used to spend a lot of time working with APCDs and others. That said, most of them aren't oriented towards this type of work. There's too many restrictions on data use and transparency. But I do think that there are assets out there that could be leveraged differently with the right partnerships. That said, I'm literally in a situation right now where we have 6 jumbo employers, including public purchasers, who want to do a data initiative using the new transparency data, the CAA data that is now available, but no one wants to pay for the infrastructure build, right? So we have a case study happening right now. So, but I do think people are ready to think differently and leverage what does exist.
Yeah, and I'm just going to quickly, this is a plug for tomorrow afternoon session on our dashboard, because we will be actually addressing the data that we're using from the ARPA-H perspective on what you're going to be, how we're going to be tracking these in the national level, and then regionally what the kind of process is once we award. So this is a plug for our dashboard and data session tomorrow afternoon to learn more.
There's a question from online. Okay. I hope I'll just read it out for the panel. The question is, how would you, the panelists, encourage potential health accelerators, whether they're organizations, nonprofits, or others, who might benefit from outcome buying from either employer philanthropy? What is the best way to connect with them and potentially get their foot in the door? In other words, how should they engage?
Online, you want to take that one first? Anyone? Dave?
I'm going to just jump in quickly, because in a past life, I actually ran a statewide regional health collaborative, and it was employers in the state and hospitals and clinicians and health plans. And coming together, you can do amazing things, but it takes that trusted, neutral convener, in my experience, to be able to do that. And it has to be, trust is the currency here, because you're asking people to work against maybe their organizational self-interest or to just change practices for sort of a collective benefit. So I know this isn't directly answering the question, but I would look for trusted community partners and then sort of build from there.
I think all of that's right. And just the place that I think offers the most upside, where the trusted convener doesn't currently exist, is the FQHC sector and the Medi-Cal population in California. There are 7.5 million human beings who get their healthcare through FQHCs in California. And we don't look at it as a system. We look at it as this disaggregated, fragmented, balkanized set of relatively small providers who don't have the resources, and we don't have, there's no, there's nothing out there that consolidates all of that so that we get to a scale that matters. And I think that's a target-rich environment. It's the largest number of people. It's, the problems that are on the list here for the HEROES program are more pronounced in that population than they are in the commercially insured population. And a third, we now live in a country where a third of the population gets their health care through Medicaid. And that was not true 10 years ago. And so if you think about it, for where are the biggest numbers, where's the biggest scale, and where do resources produce, whether philanthropic or otherwise, and I think it just screams out for political leadership at the state and local level, but also philanthropic leadership at a level that allows you to do that. And I think both of those things are possible.
Either of you care to answer?
So one thing I would say in getting in touch with us, it has to clearly have a public good. Okay, so if your comments like, well, this is just kind of an investment in some product that is really just about marketing the thing, we're not going to be interested. It has to have some public good. There has to be a through line to how this thing could actually operate, change things, either through policy or through some market intervention. We have to see the journey for the idea and how it actually has an impact. And then we expressly try and make the process not highly complicated. So it might be a 30-minute phone call just to say, this is not us, or it is, potentially. And if it's potentially, then we'll ask literally a single sheet of paper and $1, that we could kind of internally discuss. And then if that's going to go forward, then we'll ask for an actual proposal. And we try and keep the proposals very small or, limited. They're not 30 pages, that type of thing. But public benefit and a through line to some, policy impact or market impact is what I would say.
Yeah, a couple other things I just wanted to add to this conversation is that the foundation has done a lot of work serving as a neutral convening body, across a spectrum of issues. I think one thing that we recognize is that, again, I mentioned this point early on, there's always that fundamental equity or slash inequity dynamics, right? Who's in the room? Whose purse string is thicker than the others. I think our foundation, what we value the most is that we wanted to make sure that the voices of the unheard, the voices of the less powerful, less visible, are being heard, are being reflected. So that's something that's very fundamental to our foundation's belief in building community capacity. In some ways, we feel like this is a great kind of coalition building muscle exercise for us, to support our various communities. and regardless of whether they can cross the finish line, of course we love them to cross the finish line. But I just want to put it out there. And to Mark's point about public good. And I guess from our perspective, it's really about how could we fundamentally rebalance the dynamics, in terms of equity, in terms of power and influence in shaping the agenda for this work.
One more question, if we have one. Or time. All right. Well, thank you. I want to thank all the panelists so much. Thank you all for calling in. Thank you for being here.
Fantastic. Thank you so much, Claire. Thank you so much to the panelists.